We can just remember prayer tonight before we officially
Yes,
begin.
of course. Yes, I was going to, since you mentioned it, why don't you open up, since your students are one of presenting, can you do that, please? We can't do without prayer. I hadn't forgotten. We are now
Great.
live.
Great. Should I go ahead, Dr. Mack?
Yes, please.
Let us
Please.
pray. Almighty God, we give you thanks for who you are. We give you thanks, Lord, for what you have done for us thus far. Father, we commit this evening to you. We pray for our lecturer, mighty God. We pray for strength for her. We pray, mighty God, for wisdom for the students who will be presenting tonight. Father, we pray, mighty God, that you would be with us and journey with us as we would seek, mighty God, to assimilate information. Father, we commit this time to you. In your Son's name we pray and we ask. Amen.
Amen. Okay. Good evening formally, everybody who are here, and for those persons who are on YouTube, I want to thank you for it. Was a very long session last night, but I think it accomplishes purpose. And we are wrapping up the class for this evening, and just one or two announcements just to let you know that as people are determined that the exam is, we will have the take-home exam. I'll be sending that the exam to the academic authorities over the weekend. And just to let people know again that the case of Johnny Walker, instead of me sending you an official case, use that case for you to submit a project for me to look at. So what I expect you to do with that project is that you need to treat it pretty seriously. It should be done formally. We did at least do diagnosis. So what I want you to do is answer the questions, make certain you justify why you use that diagnosis, and I want you to also come up with use a treatment plan template that I gave you, and also to explain to me what made you want to use that treatment approach for this child. So basically, that's that in a nutshell. That's going to be the your group project. Again, use the guidelines that was for the project to submit this Johnny Walker case instead of me sending you another case. We really don't have time for that at this point, given all the difficulties we have been having with the technology. I don't want to burden you further, so come prepared that the discussion forum is also due. You need to let me give people time. I understand that we have a class on Monday coming, and I know people have the assignment due on Thursday, so I will, if I don't know, I'll probably try and give people, what I decide to do is give people until Monday and Wednesday of next week to complete the final discussion forum, and that's it for the class. So I want you to concentrate on getting the exam in, and if you have started already the posting, that is fine. You can still turn it in as a designated time, but just remember that I'm giving you an extra Monday and Wednesday to finalize everything. Okay? And just to, I know there is a deadline for the individual project also, so we need to, I think if during the course of this class, if people have any concerns about that, we could discuss it. But right now, what I want to do is that I will need to continue with wrapping up the notes that I have to do in terms of the syllabus. And at this time, I want to invite any questions or comments that you have at this time. Are there any?
Yes, Dr. Mark, from me, Marshall.
Yes.
I am not. Could you please remind me, when did you say the case of Johnny Walker is due? Because I don't think I got that.
We hadn't discussed. Well, the case would have been originally would have been the 6th of June. That would have been next week.
Okay.
But people, I mean, I need this thing wrapped up. Oh, okay. So because once we have things firmed up, I'll be copying it to the dean that they're aware of the deadline dates. So that we're on the same page. Well, let me hear from people. I know the exam because I prefer the exam in class, but some people are saying that the exam can be done in class to load up in 3 hours. So that put a spin on the other deadlines to be done. So what are you thinking?
Dr. Mac, I'm thinking, Dr. Mac, that if it is possible, if the case and maybe even the individual project, if possible, could be due on the 10th, which is the following Wednesday.
But you know that's going to interfere with the class time, and I don't want to, it's been said that it's interfering with class time.
Oh, I see what you mean, Dr. Mac. Well, that's if there's a consensus with the other students, Dr. Mac.
And some people are asking when we should send in our discussion forum, since we have been occupied most of this week. I did say that I'll give people until Monday, the 2nd and the 4th of June next week to turn in the discussion forum. The discussion forum is extended to Monday the 2nd and
Dr. Mac.
Yes.
Monday.
Yes. Yes.
Tuesday or Monday, Dr. Mac?
No, Monday the 2nd well, I just realized. Okay, I'm getting a bit confused here now. We had said that the exam is due on Sunday, correct?
Yes, that's Dr. Mac. And it will be posted on.
Well, the
June
thing
4th.
is that as long as people are in agreement, because I didn't want this thing interfering with the class time. That's what I was trying to avoid. So if people, let me ask people for the assignments, what dates are you in agreement with? Then that I can ask. What dates are you in agreement with?
So actually the 10th of June, Dr. Mac.
That's just one consensus.
Dr. Mac, I agree.
The 10th for me too, Dr.
Are there other people from YouTube, students, and from on the live chat? Because once I put it in writing,
yes, Michelle sends her agreement for the 10th for the individual project and group work.
Okay.
Michelle,
well, I have to let Dr. Holness know and
there's an agreement with that as well.
Okay, so you cannot complain that it's interfering with class time for the other class that you're going to have. I don't know what class is that, but students it's going to overlap, so you are responsible for the information. So when I hear you need an extension because of class, you have agreed to this, it's been recorded. I'm going to put it in writing to the dean and to the academic that we are on the same page of things to be determined to be uploaded on the Moodle. Are we in agreement with this, ladies and gentlemen?
Yes, Dr. Mac, and it seems that person on YouTube are also in agreement.
Yes,
Okay.
Michelle said she is in agreement for June 10th.
I'm trying to find a pen here to make a note to myself about that. Give me a moment. Let me go get a pen. Just a moment. I'll be back shortly.
Sure, Dr. Mac.
Robert.
Go ahead.
Robert, actually here is it? Dr. Mac is saying what? The individual project as well as the group project are
We're
due
going to
on
have
the
a
10th?
class on Monday.
Right.
Having a class on Monday?
No.
Hey, Pilot, what's up?
No, I think some other students.
Sorry.
I think other students have class on Monday.
Oh, I thought you said Dr. Mac was having a class on Monday.
No, it's a comment I saw
Okay,
from
sorry
Michelle
about that.
on
So we are making some tentative, well, not tentative, some final date. June 10th is when the assignments are due. That's the project, individual project,
And the
That's
group
the individual project.
and the group project. That's Johnny Walker. Are we on the same page?
Agree,
Yes, ma'am.
Dr. Mac.
So for the group project, you follow the what's in the syllabus, but basically those questions. I don't. This is a treatment class. I'm not expecting a lot of psychopathology. Just tell me what I ask you, but make certain that you do it in a bit comprehensive that I can, since it's a formal project. You know what the diagnosis is. You don't need to worry about that. I just want to see how you derive it. What's your reasoning, or what's the group's reasoning about that? And for the individual project, how are you going to come? Now you know how to do a treatment plan. Come up with that. So make the treatment plan. My suggestion to you is that for the treatment approach, make it comprehensive, but also link the treatment approach to the treatment goals. Let me see very clearly that you understand what a goal is, what an objective is, how you can do a target problem, etc. All right, so let's underscore again. So the discussion forum, I will have to make it the final first post is going to be on June 3rd. That's a Tuesday.
No, Dr. Mark, that's a Wednesday, Dr. Mark.
That's a Wednesday?
The Wednesday.
Yes, Dr.
I'm
Mark.
sorry. June the 2nd, I beg your pardon.
Right, that's a Tuesday.
And June the 4th. And June the 4th, the final, and that's it. No more. That's it. I cannot extend anymore.
Thank
Fair
you.
enough, Dr. Mark. We appreciate that.
Fair enough.
Okay, I'm not here to kill you, but again, you'll be getting three essays. I mean, no, 2 cases and an essay for the exam. I have not decided yet what I'll do, but I'll have some time over the weekend to do that and send it. It's a take home, so you don't need to worry about right and wrong. Just let me know that you are able to critically think about the case, articulate it, case conceptualize it, and come up with the answers. That's all you need to do for this class.
So, Dr. Mark.
Okay, let's go now.
So just let us confirm, Dr. Mark, that the individual and the group work, it is going to be the 10th of June for final submission. For the post, we have until June 2nd to make the first post, and June 4th for the post for replying to one of our colleagues.
The take-home exam is
open on the 4th and closes on the 7th.
And the take-home exam is June the 7th. It must be uploaded on the platform by 12 o'clock your time.
Great, but it will be open to us on June 4th, Dr. Mark.
Yes, Mr. Nami, please take note that the postings will be open to students for them to post, please.
Yes.
Until June 10th, everything will be open until after that. Please close it.
Okay.
Only I can see it.
Much appreciated, Dr. Mark. Thanks much.
All right. Okay, ladies and gentlemen, we have to rush now. We have a little things to cover, and we have 2 presentations tonight.
Dr. Mark.
Yes?
Just before you go, I just want to confirm, there's a question and concern on YouTube. If you have a class on Monday, just confirm that is not so.
We have no class on Monday coming. Class on Monday coming? No, we have no class. It's over.
Great, Dr. Mark.
We're done.
Yes, we have another class on Monday.
The class that I don't know what class you have on Monday. Not mine. Right. Not mine at all. I'm done.
I'll be having one on Monday, Dr. Mark.
Oh, well, not me at all. I didn't cause that. All right, let's look at treatment into document. I said about documentation quickly, and I know Mr. Nami put up a progress note on the screen that we can look at it. But let me say something quickly about documentation. That this documentation is a part of your ethical responsibility. You must keep records of your sessions with clients and patients. You need to keep records. So documentation is defined as it's really a form of record keeping, and it is seen as formal note taking. So when you do a progress note, as what we have on the screen, it is formal note taking. You are documenting You're documenting what you hear. That is the client's narrative. What you hear, the client's narrative. What you are seeing, the clinician's signs. What you see. You're documenting what you do. What you do, that is what you are doing in the sessions. What treatment techniques are you using? And lastly, you are also documenting, you're also summarizing. You're also summarizing the session. So a treatment, I'm sorry, so documenting, so a progress note is, as I said, is a formal representation of the session that was held with the client. That's formal. You don't write everything in a progress note. There are some things you just don't write in it. Always think that this file or this record is going to go to court, or it's going to be subpoenaed, or somebody's going to read it, and you have to be able to protect the client's interests. So the progress note gives you an idea of the session itself. You capture what was said. It's time sensitive. It is time sensitive. In other words, it has a start and end time. 3 p.m. to 4 p.m. session number 6. The progress note, I'm just continuing. This is not going to be in the notes I'll send you. I'm just giving you some extra information. But the progress note must talk about the current mental state of the patient. Could be adult, could be child, could be teenager, but you must talk about the mental status. Mr. X's mood was depressed. Johnny seemed anxious today than previous session. Johnny was not voicing any suicidal ideations at the time of the session. You must indicate at the time, because if anything happens, it's there, you're protected. Let me repeat. You must document anything about ideation, especially at risk patients, like teenagers who are at suicide risk. You ask, do you have any thoughts of hurting yourself, even adults? And if they say no, patient denied suicide ideation at the time of the session. Any questions? Unmute your mics. Are there any questions so far?
Dr. Mark?
Yes.
Would you ask the patient to sign to that statement, or it doesn't necessarily matter?
No. The progress note is your legal leg to stand on. It's documented and it's enough record that cannot be altered. Once the progress note goes into the academic record, once it goes into the client record, you cannot alter it.
Okay.
Let me repeat, you cannot. That is tampering with the records, and that's illegal. In some places, you can lose a license for that. You cannot do that.
Okay.
So your better bet is to make certain that you document, make certain. So some disorders need monitoring. Bipolar disorders in teenagers, depression, psychosis and combined with substance abuse. I'm talking about now going to adults. Those warrant very, very careful monitoring, especially somebody who has a history of suicide attempts. And you have some pretty sick kids out there. You have to monitor them. You have to ask them all the time. So you ask them about, so you know their mood. So mental status is important. So you note about speech, any attention problems, speech, attention, concentration, thought processes. Are there any psychotic thinking? Are there, is a speech oriented or goal? Those are things you document in a progress note. Any questions? The progress note needs to comprise, not the progress, I beg your pardon. The client record need to comprise the following materials. 1, it must comprise the original clinical interview. That is the documents. The one I showed you, the intake I showed you last night, it must have that in there. 2, the treatment plan. Treatment plan. 3, what the patient reported in the progress note. So the progress notes must say what the patient is reporting. Most importantly, listen carefully, it must have consent for treatment. It must have consent for treatment. You cannot treat a patient or a client or a child without the parent's consent. That is illegal. You have to have it. And like I said before, find out if in case of children, if the guardian is, if the person who brings the child is the legal guardian. If not, you cannot see the child. Get the parents to sign, and it's in the records. Of course, case notes or progress notes must be recorded using goals and objectives. Now let's look quickly at the treatment plan. It's up on the screen, so if you could take a moment to look at it. Oh, Mr. Nami, that's not the one. I didn't realize. There was one that had a sample that I wrote. Can you find it? I thought you had it up.
The one of the title, you said notes, you said progress notes.
Yes, but I sent one that says adolescent sample.
Okay, I will check that.
Okay, so while he's doing that, let's look at interventions briefly. So let's look at interventions and the process of change. Interventions as a heading, and the process of change quickly. Now, if you could put in your three like you're doing it's three columns. One of it is stage of counseling process. The other is, the other box is counseling relationship task, and the other is primary clinical thinking task. So you need 1, 2, so going down you need 1, 2, 3, 4 going down. So I'm going to give you the stages of counseling.
Could you repeat the headings again, Dr. Ma?
Stage of counseling process in one box, counseling relationship tasks in another, primary clinical thinking task. In the first box, which is the stage of the initial stage. Initial stage, and in it you write.
Matthew, slowly headings again, please. Slowly the headings, please.
stage of counseling process,
Yes.
counseling relationship task, and then in the next box, I didn't give you that, I'm sorry, primary clinical thinking task. Primary clinical thinking task. That's a third column, or heading, I should say. So the first box under stage is initial stage. And under the counseling relationship task is what is known as that is the interview preparation with the patient. You rapport is established, you sign documentation, you do preliminaries. Under that, the clinical interview is also done with if it's a child, the parent, any figure in the child's life that will give you information that you need. So this is the initial stage, and as I said before, you're going to do rapport building, then you're going to do problem identification. What is the problem? How can I help you?
Dr. Mark, I'm a little bit confused. I'm not sure which heading what is supposed to go under.
What are you talking about?
You started off by saying stages of counseling. Under that, or in that column,
I said initial stage.
Yes.
And I said counseling relationship task.
Yes.
Our initial preparation, like document, you talk about signing documents, etc. So you make a preliminary introductions where you sign documents, talk about what the process is, and you make it that you sign these documents. Then you're going to have rapport building.
Primary clinical tasks.
These are on the task. These are all on the task.
The clinical thinking.
These are all on the counseling relationship task.
Okay, continuing on the counseling relationship. Okay.
And then there is, and under that there is what it's called presenting complaints. You are asking the question, what is the problem? What is the problem? What's going on? So the next box, which is primary clinical thinking task, your role is to conduct an assessment and evaluation. That's what you're doing. Conduct an assessment and evaluation. And that is, and also you're going to facilitate intake and screening of what the problem is. You're going to facilitate intake and screening. Mr. Nyami, have you found that progress note yet? Is he? But he's not here.
You could look at the thing there. You could look to see.
Okay, it's there. Okay. Let's finish this and then we go to that, please. And then we have the second stage is called moderate. The moderate stage. The moderate stage. The moderate stage. And under the second box, which is counseling relationship task, we're going to look at your continuing with relationship building. You are continuing with relationship building. Then you are deepening the understanding, your understanding of the client's needs. You're going to engage in goal setting at this stage, the moderate stage. You're going to engage in goal setting. Goal setting. You're setting some goals. Under the next heading, beside it, you're gonna develop a case conceptualization of your session. You're gonna develop a case conceptualization of your session, and then you're gonna prepare treatment planning. That is, you are creating a treatment plan. The third stage is called the work stage. The work stage. Work stage. Work stage. The task is you're going to implement the treatment plan. Task is you are going to implement the treatment plan. You are also going to select an appropriate counseling intervention. You're going to select also a counseling intervention. The primary clinical task is you are going to listen carefully, and then you can write. You are going to monitor or revise diagnosis. Monitor or revise diagnosis. Continuing under that, you're going to update case. You're going to update case conceptualization process. Or adjust treatment plan. Let me go it over again. Monitor or revise the diagnosis. Update case conceptualization process. Adjust your treatment plan. So when you adjust the treatment plan, this is called, all of this is called a treatment plan review. All of this is called a treatment plan review. Let's look at the last stage, which is the final stage of the process, called final stage. You're going to start telling. You're going to start telling this about discharge, talking about discharge planning with the client. That has to be done. We talk about discharge planning. Make any referrals if necessary. Make any referrals if necessary. Go over the goals and objectives and what was accomplished and what the patient learned from treatment. And then under the thinking task, demonstrate outcome achieved. The treatment plan worked because the client got better. That's what it is. So that is basically the process in a nutshell. Are there any questions? Before I move on to something else.
Yes, Dr. Matt, repeat. Demonstrate what? In the third column.
Demonstrate outcomes that are achieved. Well, did the behavior change? Did the client learn something about being involved with you in treatment?
Can this be made available on the portal, please?
I will have to scan it and copy it. It's not in any notes.
Oh.
I have to put it together and copy it. All right, so that's it for that for now. let me go briefly over with play with you. I mean, we had oh my goodness, the treatment plan. Let's go back to the progress note. Could you put back up Mr. Nami, please? I'm sorry, or I forgot. Could you put it back up on screen, please?
Can you click on my face and you'll see it?
Okay. This is a copy of the treatment plan I did with a teenager. Not seen it. It's okay.
One second, Dr. Mark. Those people on YouTube not seeing this, you know.
Can they see it after the
You could tell them to. I'll tell them to look at it. They have it in their list. I'll tell them to probably check it.
Tell them to check it, please. Tell them to go on in their emails and check it, because I sent it to them. They have a copy of it, so they can go and look at it from email. But for the live people, this is a copy of a progress note. So note on it the date, time, and end. The session that was held, how many sessions. So you keep tab of sessions, because this is important in your treatment plan. You're going to determine how many sessions you want to have. So can we scroll down, Mr. Name?
Okay.
No, this is, as I said, this is a notice how I assessed the patient's mental status when I saw them that day. Could you continue, please? So if you notice, all this is how dealing with the mental status exam, and I believe that notes were sent on the mental status exam on the Moodle platform. So look at the content of the session. In other words, what did the client say? Okay. So I'm just going to read. Hopefully they'll be able to hear by YouTube what is being said.
They're seeing it too, not so much.
Huh?
I forgot that they're seeing it as well. So they're
seeing it. Okay, good. Notice I said the clinician was able to. No, let me say this. You need to be very formal in the progress note. You don't say I. You never say I or me. The clinician, the psychotherapist. The clinician was able to meet with the client and his family to begin the process of treating client's agoraphobia and adverse to be in social places. Father stated a report. It's not I said it, the father said this, that the client had a setback for the last 2 weeks as his pet bird had died. He had difficulty accepting the death of his pet. What am I saying? What do you think I'm saying here? What am I trying to convey? What stage do you think this is? What stage of the treatment process is this in?
Initial
First, second, or
stage.
third, or fourth?
Oh, the second.
Okay. What is the second phase? That's what? I'm trying to, what is it?
Bill, you're trying to you're trying to gain insight and
you're exploring the presenting problem that the person would have come with initially, based on your own diagnosis, Dr. Mann.
Remember, this is the 8th session, so this could be the second. I mean, is there anybody? The 8th session. What?
Oh, the 8th session.
It's a working phase.
Yes.
I thought you said the second session, Dr. Mark.
No, the 8th. I said number 8. I saw him for 8 sessions. It's the 8th session.
So in the working stage then.
Yes. So I said he had difficulty accepting the death of his pet. Appears to be depressed.
Oh, you have implemented the treatment plan then.
Appears to be depressed. Client's parents express concerns regarding the length of time for the medication to have a therapeutic effect. He will see the psychiatrist at the Child Guidance Clinic at the University of the West Indies. They discuss adjusting the schedule for his return to school. What am I doing?
And I know treatment is involved and
what am I
referral is
doing?
involved.
You're creating your case conceptualization.
Goal setting.
And I'm doing also what? I'm creating some what? Am I creating some interventions?
Interventions.
Okay.
And the adjustment of the treatment plan that would have been there.
Okay, well, listen to this. Parents express concerns that he has become increasingly depressed. Sign or symptom, ladies and gentlemen? Sign or symptom?
Patients express.
Parents express concerns that he has become increasingly depressed.
That's a symptom.
Parents express concern.
Is it parent? I thought you said patient.
Oh, sign.
No, I said parents.
Sign.
Signs.
Signs.
Yes.
Note what I said. Client still harbors ideations about wanting to die, but does not have a plan for self-harm.
That's symptom.
Where's Dr. Mark?
Reports feelings of worthlessness and helplessness. So those are the symptoms. Even though he has no desire, no harm, self-harm, he's still reporting depression, worthlessness and helplessness. So you can conclude that the patient is depressed, correct?
Right.
15-year-old teenager. Continue, Mr. Let's go, Mr. Name. Mr. Name, okay, continue. Let's. Okay, the clinician utilized cognitive restructuring to correct. Patient displayed feelings of anger and felt that God had made him on this earth to suffer. So for people doing CBT, you can see that what is the cognitive error in this case? What is the faulty cognition? Whoever is doing CBT. What's the faulty cognition rather?
Oh God.
What is the faulty condition in CBT, Mr. Barr?
It's schema. It's schema.
Yes, what kind of schema, Mr. Barr?
In terms of his thought process, based on his own belief about God and himself.
No, this is called personalization. That's a cognitive error in CBT, in Beck's theory. We didn't put it there, but it's really personalization. Okay, so recommended play therapy as a modality is used as client appears to be much regressed. Client agrees to work with this strategy. So you're seeing what I'm doing? I'm doing interventions. I'm telling you what I'm doing in the session. Do you see that?
Yes.
Discuss, anybody from YouTube, any questions? Discuss plans to stabilize the family structure with parents and to discuss the behavioral modification plan to deal with clients' behaviors. So what intervention am I also taking again? This is a treatment. What behavioral, what other, what?
Is it a part of family therapy involving the family?
Behavioral modification plan? What treatment approach is that? That uses that? Come, we are doing this. We're just doing notes on the platform. There's no reason why you should know what treatment approach uses a behavioral modification plan.
CBT, behavioral.
Behavioral uses
or
that.
CBT.
Yes. Okay, we'll discuss contract with parents. Concerned by the therapist for the child's mother who appeared to be anxious and irritable. So there are some family dynamics going on. It appears that she may need some support. We'll discuss the possibility with the child's parents in another scheduled session. Remember we talked about avoiding, when you're talking with people, to avoid the matter of colluding. So we discuss this in another session, which is appropriate. Can you continue, Mr. Nami? Could you scroll that we can see more, please? Okay, so interpretation of a session. Let's just do that. Scroll, please. Patient. This is case conceptualization, and it takes what you are able to bring to understanding what you're thinking is the problem. Patient has been dealing with internalized guilt and shaming experiences from childhood. Therapist has been able to utilize cognitive behavioral techniques to deal with irrational thoughts and dysfunctional belief systems about how he views himself and the world. What theory is that? Which one? Which one is that? Which theory is that? Which CBT theory? Mr. Barr and Company, which CBT theory is that? And others. No.
Can you please repeat that?
Which treatment approach deals with himself and the world, others and the world? Beck's cognitive therapy.
Oh, yeah.
Okay, so cognitive restructuring of thoughts. Client to be seen at child guidance clinic for review of management with a view to increase dosage to increase. That is the medication. Could you continue, please? Let's wrap up to see if there are any treatment goals, Mr. Nyame. Okay. Treatment plan goals and objective. This, you see, decrease symptoms of the. That is what I'm focusing on today. Now you notice. Look at the goal and remember what I just said. Did it fulfill what I was trying to accomplish in this with this child with this goal? Decrease symptoms of depression as evidenced by patient being compliant with taking. Now, what can you see in this treatment? What can you see?
Evidenced by patient being compliant.
What can't see, and what's the goal? What's the objective?
The goal.
What is the goal?
The
What
goal
is the objective?
The goal is to reshape his thinking.
Look at the treatment, look at the goal that I worked on, and tell me what the goal is and what the objective is.
I'm not seeing it.
The goal is to decrease symptoms of this.
The goal is the goal in front of you and the objective. What it is, they're together. Which is the goal? What is the objective? I just did it last night.
The goal is to decrease the depression, and the
objective is
the other one is
being compliant.
Take medication. Which can you see?
The patient being
compliant. That's the objective.
That's the object, yes. And the goal is concrete.
Decrease the depression.
You can't see that. Can you see that?
No.
It's operational.
And in the depression.
All right. So, do you understand now how progress notes are to be written?
Yes, Dr. Mac.
Yes, Dr. Mac.
Any other questions you need to ask me before we come up with this? Any questions from YouTube? Any questions from the live chat?
None from me.
None from me, but the YouTube will take a while for them to hear if you're asking for questions, because it takes a while to feed to them.
All right. Well, if they need to, then I'll answer it. But is it clear, ladies and gentlemen, what it is? Is it now clear?
Yes, ma'am.
Okay. All right. So you can take this off the screen now, Mr. Nyamin. Thank you. So we are going to now, I think, let's do some special topics quickly. I need to just get that in. May I suggest that the special topics were also recorded for last year, and I did it. If we don't finish, you can go back and listen to it. Okay? Am I clear?
Yes, Dr. Mac.
So let's look at some special topics. All right, let's look quickly at how to deal with let's do this. There are teenagers. There are 3 types of teenagers. This is just from my experience working with teenagers. I've come up with these 3 types. 3 types of teenagers. 1, the problem-focused adolescent. Problem-focused adolescent. No, this person is known as the identified patient. The problem-focused adolescent, known as the identified patient. The family dysfunction is represented by the patient's behavior. The family dysfunction is represented by the patient's behavior. More than one, you don't have to write this, but you can listen, you can take notes later on. That a lot of times, sometimes teenagers come to you, they're doing very well, they're academically brilliant, they're bright, but somehow the family dynamics is not doing very well, and so they're trying to do well in school, but they're trying to hold the glue to the family. So there's dysfunction. Sometimes the teenager can behave in mature ways and mature adult ways. This teenager can also sometimes be there's underlying feelings of depression, but it comes out as a mild depressive disorder. They can have underlying depression, which is a mild depressive disorder. They're overachievers. Overachievers. There's parental pressure to succeed. Parental pressure to succeed. Parental interaction can be very distant or suffocating. Often, family therapy is needed, an individual for this kind of teenager. That is in my experience. Family therapy, more structural family, structural family therapy. That's one type of teenager. The second type of teenager you need to know about is what I call the power-inflated teenager.
The power what?
The power-inflated teenager. This type of teen is the scapegoat. It's the family scapegoat. Family. Blame is always channeled to this teenager for problems. responding to a chaotic, permissive environment, family environment. There are behavioral problems. Behavioral problems can be sexual acting out, drugs, gangs, tend to externalize the problem. They tend to externalize the problem for attention, usually for attention. Externalize the problem, usually for attention. They're loners. They're loners. Socially inept, isolated, poor academic performance. Parents can be very controlling, want the child to be fixed in an instant without having to participate in treatment. So watch out for that. At risk for conduct disorder, substance abuse, eating disorders, or eating problems if it's a female. Power is more a reaction formation to bolster self-esteem. Parents are not, family dynamics is very, very disjointed, and there's no interaction in the family. Transactional analysis is a preferred mode of intervention to deal with the ego adult state and child state, rather.
Dr. Mark, could you repeat transaction is what?
Repeat what? Repeat what?
You mentioned something a while ago about transactional analysis.
I said transactional analysis can be used to work with, especially the understanding the child-adult stage, the conflict with that, with this power-inflated teenager. So power is misplaced because there's poor self-esteem. So transactional analysis will help as a treatment modality for teenagers. Also, strategic family therapy to help the parents deal with communication, which is crucial in restoring the balance. With communication is important in that kind of family dynamic. Okay, the third and final is what I call the psychological conflicted teenager. This type of teenager is what I call the sponge of the family. They soak in everything. They soak in problems. They take on problems of the family dynamics. They have serious, their issues often come from childhood, early childhood, and come into teenage, into adolescent stage, unresolved. They're often depressed. And in Erickson's stage theory, identity versus role confusion. Identity versus role confusion. Subject of bullies or bullying from their peers. Ostracized by their peers. Socially inept. At risk for acting out suicidal acting out rather, and for substance abuse, at risk for suicide acting out. Often have sometimes issues with sexuality and sexual orientation. Believe it or not, yes. They also, note very carefully, they also sometimes can engage in cutting and self-mutilating behaviors. Cutting, self-mutilating behaviors. So they're at risk for development of personality disorders later on. Cutting, self-mutilation, binging. Take on a typical culture like goth, the goth culture. Familiar with that in Jamaica, that has taken over the goth culture? Unmute your mics.
Yes, Dr. Mark, the Gothic culture.
Yeah, it is there, and that's what I, in terms of my assessment, yes.
The tattoo in that thing.
I'm sorry? But they're basically depressed, so they tend to internalize the depression, and so they feel very alone. The families are also very very distant. Father can be absent. Mother can be domineering. Sibling rivalry. And they don't feel a part of their family. They feel estranged and isolated. These are your teenagers, even beyond Jamaica, who go join ISIS.
Only in Canada, Dr. Mark.
In the United States too, and England.
Yeah, those countries, Dr. Mark.
But basically, so you really do need to these kind of teenagers will need more long term. I believe they need more long term client centered psychodynamic theory to talk about they're troubled. So you want to talk about childhood past issues to resolve it. And you would also need the parents to be involved. Very difficult because the parents want you to, the parents sometimes tend to come from homes or economic that they don't seem to understand that their world is how their practice, their interaction is destroying the child. Okay, basically that's it for the any questions so far in your work for the future? Would you find these three teenagers useful? Hello?
Yes, Dr. Mann. Yes,
yes, Dr. Mann.
Okay, yes. So that's it. So let me just talk about couple children, how to deal with them. As I said before, I'm going to mention two couple. The video, the lecture is there for you to look at because we run out of time and we have to get to the presentation. And I just wanted to talk about the depressed child for a little while. Just types of teenagers. I mean, for the rest, you can listen to the last lecture I did last year. But I just want to talk about one or two. Now, the depressed child. Somebody I think it was Nadia that asked about how do you talk about the children who are depressed? Was it you, Miss Crawford? Miss Crawford?
It's Dr. Mark. Sorry.
So it's very difficult to know when a child is depressed, but there are ways you can know. Depressed children, depression in children is different than it is in an adult. Not hearing the questions from YouTube, but any questions from YouTube, are they understanding? I'm not hearing any. Nothing is being fielded, so I don't know what's happening. Are they understanding? Any questions from YouTube? But depression in a child is different than an adult. Depression in a child is behavioral. In an adult, it's cognitive. Depression in a child is more behavioral. They act out their depression. Depression in an adult is more cognitive. It's more, depression in a child is external. Depression in an adult is internal. Depression in children is manifested by a preoccupation or a fixation on atypical things. For example, fascination with drugs, sexual promiscuity, fighting, joining gangs, aggression. You cannot always tell unless you have to ask them. You have to take a history. So history taking is important in determining a history, a pattern of depression in teenagers. More often than one, when children are depressed or teenagers are depressed, there is another disorder underlying that, like anxiety, social phobia. They're shy, introverted. They can also regress. If they regress, there's enuresis, night terrors, enuresis, night terrors. Okay, somebody said made a comment and I read it afterwards, but there's night terrors, there's sleep disturbances, some people do go into eating this, they binge or they overeat. Well, not eating, but they binge. It's a way of dealing with their emotions. You need to, so you need to assess. It's often needed. You need to really assess the child or teenager through assessment, like you do a Beck's depression inventory for children, or the children depression inventory to determine and track their depression. So you need empirical information to track it. So in most cases, a score of 20 or more on one of these scales is moderately depressed. Then you need to pay attention. They're at risk for suicide. Let me repeat. So you can. So there are depression inventories that they can use. Beck's depression inventory for children, I believe, and there is a children's depression inventory that you can also use. And if the score is over 20, it's moderately depressed, and you need to be very concerned, because they tend to, depressed children tend to also, they more find that they're depressed. You find that they tend to have more aches and pains. Aches and pains. So their depression is more manifested physically. They have headaches. They feel tired all the time. They're irritable. They're converting their emotions through physical symptoms. They need to be medicated. They need to be on an antidepressant. So you need to send them to see a psychiatrist or a medical doctor, and you need to they need individual therapy, treatment, and follow-up. Any questions so far?
Yes, I was just wondering, when a child is placed on medication, wouldn't that child become dependent on it after a while?
No, not necessarily. Why would you say that?
And what about the side effects?
Okay, there are probably side effects for the medication.
Do they have special dosage for children?
Yes.
Oh.
Yes. That's why you should be sent to a child psychiatrist.
Child psychiatrist.
Yeah, a doctor who specializes in children disorders, because you need to remember that the depression, this is why in the DSM-5, as it progresses, you are going to see different types of symptoms manifest in children. So for a diagnosis of depression, it must be 2 years in a child and a year in an adult. It takes longer. The symptoms are different, but there are some things you need to spot in a child who is lethargic, they're not concentrating, in attention problems, poor academic performance. Suddenly they want to be by themselves, they're crying all the time, they're sensitive. These are things you need to ask, and so you ask about how do you tell. You need to interview and get information.
I was thinking though, Dr. Matt, that in our context, not many persons are really receptive to the idea of getting counseling, because there's a strong stigma attached that once you come into therapy, something is wrong with you mentally. So I'm just trying to imagine a parent, who comes with a child who is depressed and is, referred for medication. I'm just thinking that parent may not want to follow through with the medication for the child, because they may think that we're saying that their child is crazy, because to them, once it's not a physical ailment, well, they've not seen the physiology of it, but once it's not a physical ailment in their minds, they may think that, we're discriminating, or we're saying that their child is mentally ill.
Well, yes, I understand, but your responsibility is to make certain that this is why the progress note and documenting the session with the parent. I spoke to Miss X about her daughter, Julie, who seems to be very depressed, and made recommendations. She apparently seemed to have some difficulties or conflicted about the medication, but you make sure that you document. Let me give an example in my case. I lost a patient, a 16-year-old student, she's 17, to suicide. When I was working in the States, I told, so the dynamics of the mother is that this mother was, she had difficulties with her child's father and wasn't involved, but this mother was, I think she was one of the teenagers that was very conflicted. So she came initially, the initial referral was she was smoking marijuana.
Okay.
That was initial for treatment as an addiction. But in further investigating, it was found that she had the marijuana was secondary to her depression. She was using it to mask her feelings. And she kept saying, I don't want to be here. I don't want to be in this world. And I said, tell me why. And I said, what makes you not want to be here? So we worked on two things. We worked on the depression, helping her deal with what was happening, and helping her deal with the marijuana abuse. And I had to have her tested because she was smoking marijuana. But suffice to say, we tried to get her to see the child psychiatrist. Every time we made an appointment, the mother canceled it. Until one day, I documented in the medical records electronically. You have electronic charts in North America. You don't have writing on charts anymore. Everything is on the computer. But so we documented, but didn't see her for a little while. I was concerned. I tried to call, but you document. That's why I said in practicum. And I'm hoping HO is that if the patient doesn't show, you document it. Patient did not show up. It may be a treatment issue. But anyway, didn't see her for a little while, and so called, documented, but then the mother showed up, and I said, so I told my manager that I haven't seen this patient, and she had said she wanted to see. So he thought that she was going to sue the hospital and sue me. But anyway, she was saying that basically what happened is that the daughter committed suicide, and she committed suicide in her home, but that when the mother came at the door, she could be seen hanging from wherever she was, the stairs or whatever. She killed herself. Was I to be blamed? I don't think so. I told her she's depressed, she needs medication. She keeps saying, I don't want to be here, meaning that she was going to die. She had a plan. So do you have a plan? No. But you really can't monitor people and police people for 24/7. You just can't do that. But you document. That's your responsibility. Patient did not have a plan at the time of the session. That covers you legally. So what I'm saying is you mix with children and teenagers, especially you document, listen for ideations. I don't want to be here. I want to die. Tell me what makes you think that way. Do you have a plan to hurt yourself? So you ask for a plan. Well, I have a knife, I have guns, I have pills I'm going to swallow. Those are signs of red flags that you need to take action. So you need to be I don't care if it is the people it's a culture, you have an ethical responsibility to protect your clients. Are there any questions? Any questions?
Yes, Dr. Mac.
From me at this time.
Didn't hear you.
From me at this time.
Okay, anybody else?
Yes, Dr. Mac. In a situation where you have, for example, looking back on the 3 types of teenagers, all 3 of them, in my opinion, need some sort of family therapy.
Yes, I agree. It's basically what it is. But you need to also do individual with them also.
Right. But in a situation where like the parents come and they say they want this child to be fixed because they don't deal with anything and whatever the situation is, but yet parents are not willing to engage in family therapy or be a part of, because they think the problem is with the child, not with them.
Well, this is where psych education comes in. I know people talk about psychoeducation. We talked about that at some point in the course here, that you need to sit down with, because sometimes parents don't understand that their behavior and the dynamics in which they behave create these problems, and they create the kind of homeostasis in the family dynamics that the child can produce these 3 types of teenagers as I talked about. So you need to at the outset say, I know, but I think that one of the things that will help treatment is that if you are involved also. And here's why you need to be involved. So once they are aware of the outset as to what is needed, then you can invite them, and because you don't want to create that isolation from treatment. You also involve them at the outset. Explain why they need to be involved in treatment and put it as a part of the treatment plan. Client's ex-parents will be part of it, as evidenced by 1 to 2 weeks of family psychoeducational giving a handout on. So it must be in the treatment plan.
Okay.
Any other question before we move on? We have to soon get to the presentations quickly. Any other question? Any other question? Let me take a final one, or take another one. Let's look at the aggressive oppositional child, and then now the oppositional child is a lesser problem. It's a sign of a child who is in conflict with authority, with parents, and frustrated and angry. Okay, this type of child, these are younger children, angry, upset, frustrated. They tend to not be able to communicate very well, very poor boundaries. Very poor boundaries, poor discipline, inconsistent, I should say. temperament. They may have a very irritable temperament in terms of the temperament with the child. Parents are not. There is as I said, there is, in terms of the attachment is basically insecure. And so when a child develops oppositional behaviors, they are acting out their frustrations and ability to communicate what you're feeling. So they're externalizing what you're feeling. And in my experience, oppositional children tend to have low IQ. Low IQ, intelligence quotient. There are also learning problems. There's academic learning problems. Issues with peers. Don't get along with peers very well. Sometimes they can be bullies. They're prone to be bullies. Or there's a disposition for them to become a bully, I should say. You work with this child by trying to set limits in the session, what you're about. So you have a session with the parent and you talk about what's expected, and you talk to the child about that. You at least you communicate your understanding of the frustration. So you need to be able to communicate that to the child, they understand. An oppositional child, you have to teach them about inappropriate behavior. They have to be taught. So with a child like this, you can use therapeutic games. Now I know there are a lot of therapeutic games you can teach a child about anger. There are stories about anger, games about how to manage, regulate emotions, feelings. Yes. Use therapeutic games. You also use contracts about changing behaviors, like tokens. So it's more practical in nature when dealing with an oppositional child. And then you have to also find out the source of the oppositional behavior. And also that the parents have also got to work with you for the child to change. Because if you set up a behavioral plan and you condition the child to the behaviors, then they go home and it's undone. Lastly, now I want to talk about the children of divorce parents. The divorce, very common. You'll find in child therapy, divorce. It's very devastating. Children have a difficult time with dealing with a separation from a parent. It's a trauma in itself. It's an environmental stressor. So most children with a divorce, they come in an adjustment disorder. So they may come with adjustment disorder with depressed mood or anxiety, or if it's prolonged, depending on the nature of the divorce itself, the child may develop depressive symptoms. So so you need to guard against two types of children with divorce. One is that the parents, they are cooperative, but they are involved in the child's life. They are cooperative and they're involved in the child's life when they divorce. So they work towards making certain that the child, even though there's a divorce, that there is some amount of stability. And there's another set of parents that they are fighting all the time and they're attacking, and so it creates much more stress and trauma in the child. So in a divorce case, quickly, you have to determine, the children come with the fact that they blame themselves for what has happened in the divorce. They blame themselves. There is loss of parental object. They tend to blame. There is loss of parental object. Loss of the family structure. Loss of family structure. And of course, there's going to be loss of predictability, consistency, and stableness. And with the parents, they mostly have lost what I call the loss of the ability to parent. There is the loss of the ability to parent. So you may find a parent who's overindulging. They give the child whatever they want. They go to one house and they stay up all night. Another parent, they try to maintain a matter of discipline, creates a problem. You ever heard of, does that ever occur to you? Have you ever heard of in anybody? Any examples in your situation?
Because there's no consistency.
Mm-hmm.
And so the child is confused. I was reading something like that, where that the child will go one parent.
Well, it's crucial
that parent is organized and responsible, and then when they go to the other parent, they can't find their stuff to go to school because that parent doesn't ensure that they have their bag before they go to school. So when they go back to the home now where they have to be organized, it's sort of confusing for them. And then
it can create very serious psychological problems because you have to have consistency, and it tears on a child. But this is what you need to know about divorcing children, that they're going to tell you 3 wishes I have, the 3 wishes. I want mom and dad to be back together. They say that. I want mom and dad can come back together again. It's the loss of this object, love of object. To note. The aim is not to make the parents come back together. It may never happen. But the aim is for the child to accept it and for the parents to work for the child's best interest. In a divorce case, you are responsible for the child's best interest. So you're going to have to work to have parents come into treatment, both of them, and show the child about that, even though 2 adults don't love each other anymore, they don't disagree, this is how we are going to teach you for life, that when we have problems, we work it through. Is it clear? Is it clear?
Clear, Dr. Mac. But Dr. Mac, what if the child is unwilling to accept that reality? How do you then work through that kind of difficulty with the child?
That's a good question. When I think, children are sometimes can be in denial stage also, and they have not reached the point where they accept it. They're still in that denial. It's like grieving, like a death, and you're going to the stage of grieving. So there's denial. Remember the stages of grief with Kubler-Ross?
Yeah,
I don't believe it happened.
I remember this.
So they go through that stage. So your role is with divorce there are special types of
Dr. Mac.
of games. My 2 homes. There are games that you can have for children, but those games you have to get them, especially in here in North America, and you really have to probably have well, somewhat with that, because sometimes they're very strict about licenses and professionals with those, because those are therapeutic books and you have to understand child development. But there are books you can get. There are stories the child can, games, stories the child can learn, especially young children. My two homes were dad's house, mom's house, and I think I have that game. And for the older, what's that?
You mentioned something, and it kind of struck a nerve a while ago, in relation to the grieving process, because maybe the child is actually going through those grieving stages because of the sense of loss. So I am wondering if you could actually use the stages of grief and work it through that particular individual.
How would you do that? How would you do that?
If you think about it, Dr. Mack, you said a while ago that the child is in denial.
Yes.
And if the child is in denial, then chances are that may move into anger, then move into the depression, and then begin to bargain, and then finally the child will come to a stage where they shall accept the reality of what is happening. I'm just thinking.
But it depends on this. Yes, that's good, but it depends on the age and stage of the development of the child, because some children cannot articulate their feelings. Even teenagers, they may not be able to I don't know, they don't want to talk about it. So you find ways of means of dealing with it. That's why I'm saying that games will help you to deal with it. And so there are therapeutic games that will be able to mute or to soften the pain of this, where the child is able to talk about. So I mean, but there's a number of games out there. I will have to help. I will have to just find out and send to people what you can get, what kind of games are for divorce. But there are a number of games here. Somebody's asking a question. I have experienced a student of a parent who was separated initially. I thought the parents were still together because they came to school together. After speaking with them and observing the child's responses, I realized that the separation negatively affected the child, especially since a step-parent was involved. You know, this is a problem. Step-parent, this is why I believe, and I'm going to say it here, and I said it to the other students last year, be careful even with your relationships with children. Even planning, recommended that you plan, having children, you plan and ask a child, how about, do you think you would want a sister? Because if you don't, sometimes we tend to take children and their feelings for granted. So it's important that even you in your own lives, that you, because sometimes children don't take on a sibling very, very well. They get up jealous and they act out. So even your own relationships, you have to be able to gauge how you work with your own child.
Yes.
Or how you observe your child.
Can I make a comment?
Yes.
Just based on what Robert said, that if the child is in denial stage and works through, they could probably work through. But then I remember I was reading the book from Kubler-Ross, and she said that not everyone necessarily goes through the stages as they are ordered, as she has them.
She's correct, yes.
And I don't think that's also that everyone in stages when they are grieving. So I just wanted to make that point, that they may not go through the stages as they're ordered, and they may not experience all those stages.
Well, that is true, but for children, but most children of divorce, I mean, children who are experiencing divorce, do have similar behaviors. They're sad, they're depressed, they act out, they're angry, they act out in different ways depending on what, and they act out. Some internalize it, some act out. So they do respond in a way of loss. They all do. It's how they do it. It's how they do the loss. Mr. Nyame, last thing we're going to do before this, put up the play session. I want to show the students some play, some scenes of play and interpreting play. One with a divorce scene. We can tie this in. And we can tie in play therapy. Could you put up that play therapy PowerPoint, please?
Where is it, Dr. Mark? I didn't find it. Is it on Moodle?
Yes, it's on Moodle. It's on week 4 on the notes. Week 4's notes. It's play therapy. Let me see. I had some. Yes, I want to show them. It's called Play Therapy presentation, June 15, 2010. I did a presentation. I don't remember where I did it, but I did it down there. Put it up. Could you look and put it up, and I could send it to you.
What did you say? But
yes, under notes, there's a number of PowerPoints and PDF files in there, I believe. Let's tie this in because this is one of the major plays. Is one of the major interventions for children. So, so if you could put it up, and then this is what we're going to start with doing the presentations. Did you see it? Did you find it?
Play therapy presentation, June. Yes, I found it.
Yes, put it up, please. Put it up quickly, please. I'm gonna show them some how to interpret play scenes, and then that's it for me for the on this Saturday of Jordan. But so play. I don't know. Have anybody ever know what play therapy is? Anybody? You have heard of it? Anybody? Anybody?
Yes, I've heard of it.
What do you think it is?
Well,
go to the very top, Mr. What's that?
It's basically understanding a child's world through play.
Yes.
Where you observe how they interact with the toys and even with each other.
Yes.
And from that you can get some themes of what is happening, whether at school or at home.
Anybody else? Anybody from YouTube?
What I think it is, Dr. Matt, is that children may not be able to verbalize things. And so, because through play is that they're telling their story through play.
Yes.
So that is what play therapy is. So the therapist now gets a chance to observe through play with the child telling their own story from their perspective. And it's not, they're not pressured, so they're not questioned and answer questions. So they're in their own little world, comfortable.
Yes.
And giving the therapist an experience of their own world.
Yes.
Yes, the same.
So do we all play as adults?
Well, I do, sometimes.
Do we play as adults? Is it healthy to play?
No.
Anybody?
Yes, Dr. Matt, it helps with the emotions. It helps you to relax. So even as adults, because with my son I do play, and it's something that laughing and moving around and getting to be silly sometimes it helps.
Yes.
I posted a comment from Victor.
Okay, I was not. Let me go back to what is he saying? Okay, it's about using toys to understand what is going on. Yes, yes. So there are some children who can't articulate. That is why I said the developmental stage is important, and play is one major treatment intervention that you can use with children, even teens who are regressed, to be able to connect to their feelings. It's the therapist going into the inner world of the child. Okay? It's the therapist going into the inner world of the child and able to connect with the child's unresolved issues that they need at that point. Because in children's problems are different. Sometimes a child's problems can manifest itself It can manifest itself, and it can repeat itself until it's resolved. It's needed. So once it's resolved, it stops. I don't want to play anymore. They have done it with it. It's not like an adult who continues in terms of, so children tend to behavioral or operationalize their emotions through the external. So they're more tactile in the environment. They touch things. And as they touch toys that has symbolic meaning for them, they tend to resolve their issues.
Dr. Mac, I have a question.
Yes.
I'm trying to figure what's the difference between the therapeutic play and the regular play, because I know for the therapeutic play, you give them specific toys to play with, but when they're playing in their natural environment at home, you know, they don't necessarily, you know, select anything specific. You're not observing.
Yes, there are two types of plays, or there are several types. There is one that is called parallel play. Parallel play is when a child plays in conjunction alone and plays in conjunction with another child. Okay, and there is but regular play is that children regular play is where the child is able to interact with the world itself and is able to build on cognitions, build their ability to interact with the environment, and to be able to develop and mature by solving problems. Someone says play is a natural way in which children, especially younger children, communicate, express themselves as children. Yes.
Elfreda also said something. She can't be heard in the chat, but she's there.
But it helps children to interact with real situations through play. Yes. Mr. Nami, could we quickly go through, because I want to show them about some play scenes and go through them quickly that we can go to the presentations. I know we're going to have a long. Can you scroll that we can go through and I tell you when to stop? Go through, please. I'm also going through what I have here on.
Are you seeing what I'm going through?
Yes, I am.
Okay.
Go ahead. Look, they can read on history. I just want to look at the key components, and then I will go and I'll look at some play scenes, and then we're going to stop with that.
Okay.
This was a big presentation I did at University of West Indies. I don't remember what I did it for, but I did do it 5 years ago. And it talks about major techniques of play. You can go through the handout. I know it's on the YouTube. I mean, not YouTube, it's on the Moodle platform under the notes. So just know that as therapists, you have to see you have to see the world as of a child. You can't see the world. You can't work with children as an adult. You have to see their world as you have to go into their world to see it as they see it. How many people have ever seen a playroom before? How many persons have ever seen a playroom?
I have.
No, I have not.
Well, there was one at the counseling center. Okay, stop it there. You see, that's what a playroom looks like. You see it? The different toys, for example, there are different toys express certain emotions. Like you have the aggression toys, like alligators, guns, fire trucks. Those things deal with emotions, the raw feelings. You have other toys like tactile feeling toys, like putty, Play-Doh, balls that you can roll up that deals with the child's being able to tactile, to getting kinesthetic feelings and interacting in the environment. You have toys like the nurture toys, like dolls, mother, father. Then you have toys that deal with crises, like you have like a water gun, you have a hospital, you have. So there are toys that are similar that tend to deal with the look at life themes. The family house, like a dollhouse. A dollhouse is pivotal because a dollhouse will give you an idea of the nature of the dynamics of the child's family. A dollhouse has like a house, parents, or who lives in the house. It will give you an idea. Some of these toys may be used to help children express how they feel and how they understand what is going on around them in terms of relating to others. It helps young children to understand who they are about the environment. Continue, Mr. Nyame.
From Renee.
Yes. Let's go to scenes of play. Let's go straight to that, and I'll try to introduce for the students because we need to start now. Let's go to the scenes. There's some play therapy scenes. Let's see if we can go to that. Then we're gonna stop. I think it's let me see. It's on slide. Start from slide 44 and onwards, Mr. Nyame.
I don't think I can go there just so my thing don't allow me to do that. So let me just.
Okay. In the meantime, are there any questions so far on play? There is a book I want you to all get if you can. It's called The Art of the Relationship by Gary Landreth. The Art of the Play Therapy Relationship by Gary Landreth.
I posted another comment from Renee.
Okay. Okay, there is one at Michael University College, and we were exposed to portable play. Good, very good. Okay. Have you come up with it yet?
No, it's not there.
What?
It don't say depression. That was the end of the thing.
Which one?
That was
play therapy presentation June 15, 2010.
Yes.
What did it stop to?
It stopped at pictures.
No, that's what I'm saying. Stop at the pictures and bring stop at the pictures. The first one, let me just take a couple and explain to the students what it means.
Okay.
Just put it up.
It's up.
I can't see it.
Click on my face.
Okay.
It's not seeing?
No.
Oh, maybe it went off then. 1 second.
Okay. In the meantime, students, while we're doing this, group 3 to load. Okay, quickly. Now, quickly, can you tell me what you see here? What comes to mind when you see this picture? Anybody, YouTube students, and what comes to mind when you see that picture? What are you seeing? What are your thoughts?
The worst scene.
What's that?
That looks like a war scene.
Okay, so what hypothesis would you hypothesize about a case like a war scene with a child This was a 9-year-old boy.
In the home.
Yes, his toys pretty much, Dr. Mark, are military in nature,
Yes.
and he has watched quite a number of military shows to suggest that even the joint itself is very fortified, because
Yes.
I see two tier in terms of defense, one in the brown and one in the gray, and of course the tank they're giving coverage.
Oh, he has played a lot
Yeah,
of
man.
games. The
This
games.
this
The games.
this is very tactical, Dr. Mark, in my opinion.
Okay. So in terms of psychological conflicts, what do you think is happening? What do you suggest is happening? What do you think is happening?
To be honest,
I don't
Dr.
know,
Mark,
maybe parents are strict.
Okay, all right. This is a case of the child's mind playing out two parents who fight all the time. When they fight, things happen in the home. Things get turned over, people get hurt, and so they have to be guarded. And so the soldiers behind the barricades are being protected from what's going on outside. So this is a young man who, if I recall, his father was an alcoholic, mother worked alone. Father wasn't in and out of the child's life. Child had difficulty dealing with mother worked in a car factory in Detroit, but she worked most of the night, so most of the time child was shifted from house to house. There was not stability. So basically he was showing what was going on in the home, how the parents cooperate, they fight, they're distant, there's aggression, and he's acting out and he's angry. That's basically what it's showing. All right, one more picture, one or two more pictures, Mr. Nami.
There are some comments from YouTube.
Okay.
I paid money.
Yes, now the picture depicts someone who is exposed to hostility, yes? Has been exposed to violence in his community or TV, yes? Okay, stop it there. This one is the one. Now look at this picture and tell me what you think. Very bright child, I remembered him, very bright, very smart. But he was 10, but he was, what do you think? If you can see it, tell me what you think is happening here.
Look confused to me.
Confused about what? What are your hypotheses? This is projective drawings anyway. So projective drawings, and there's an art and a skill to be able to interpret drawings.
That's right.
When you reach my level of skill.
So true.
But basically, what are you seeing?
I think he's thinking about several things, Dr. Mac. And he's in the center, and pretty much around him there is so much confusion.
Yes.
His mood changes.
Yeah.
His mood changes constantly.
Yes.
He thinks about I'm not sure if that drawing to your left, where the male and the female are parents.
Yes.
Not sure, but male and female there. And of course, there are some other articles to your right that also are a part of the mix that maybe is causing problems also in the home.
Well, anybody else before I comment on it?
I agree with you, and it seems as if realizing all of the things that are happening around him.
I am also looking at the drawing in and of itself. On the left, the drawing is very detailed. I mean, in terms of the type of the skill that this young man has.
Yes.
So it looks, and then on the right, he's very a scene like it's less detailed. So you have a stickman versus a a drawing that is with, I don't know how to. He's more creative or more detailed on the left than he's on the right. I'm seeing a bit of depression. I'm seeing confusion, and I don't know what this act is about. And I'm thinking maybe these two persons are experienced.
Anybody else? Because I need to comment. This is a picture of a child who is showing stage of regression. From you look at the picture of a young man who's showing his developmental age, and then he start regressing. So you look at the pictures on the right hand, your right, your left, of a child who's behaving like a 4-year-old. So this is who went through a very horrible divorce. Parents were parting, and he's confused. He's confused about school. He's having a lot of problem having to balance the divorce and how it's affecting him. So you note how he's showing signs of depression. There's anger. These are ego states in terms of transactional analysis. On your right, my right, your left. These are ego states. He's going through anger, feelings of sadness, confusion. And so the more he started to project or deal with the drawings, the more he started regressing.
I posted a comment from Renee.
Okay. So there's a projected drawing about a child with a divorce case. All right, we're going to stop there. I mean, you can go through you have the PowerPoint is there. You can feel free to go through it. It's there and we're going to have to now stop at this time and start with the presentation. All right, let's do that. So group 3, put your presentation up and let's go through quickly. And let's go through and won't penalize you for time, but let's start. I mean, so if you have any more questions about interpretation of play, I'll be happy to answer them by email. But let's put up. So group 3, let's start getting ready for the presentation. And just a reminder that if you need to listen to the full lectures last year, they're there for you to listen to them. Group 3, I think it's CBT, if I'm not mistaken. Is it?
No, REB.
Oh, REB. I'm sorry.
Just waiting on Kojo, Dr. Mark.
Okay. In the interim, while you're waiting, could you introduce yourselves and what you did and all that for time, please?
Okay, good afternoon or good evening, Dr. Mark and colleagues.
Good evening.
Group 3 will be presenting on rational emotive behavioral therapy and how it can be used to treat separation anxiety disorder. The presenters are Patricia McLean, Roy Mitchell, Rhonda Bedward, and Anthony Johnson. We are hoping and aiming that at the end of our presentation, our colleagues would be able to operate on 4 domains, and the first one is to define REBT and to state the basic concepts of the treatment method, identify the diagnostic features of separation anxiety. Thirdly, be able to assess the effectiveness of REBT to successfully treat separation anxiety disorder. And finally, state the importance of selecting an appropriate treatment for childhood disorders. I'm going to turn over to Rowena Mitchell, who will take us through the history and the background of REBT.
Okay. Good afternoon. History and background of REBT. REBT was introduced in 1955 by Dr. Albert Ellis, who had become frustrated with the ineffectiveness of psychotherapy. Dr. Ellis was born at Pittsburgh, USA in September 27, 1913, published more than 800 scientific papers. was shy with girls during his adolescence, making himself talk to 100 girls at a Bronx botanical garden during 1 month period. Although he did not get a date, this method reduced his fear of rejection. He died at age 93. REBT was birthed through a combination of philosophical and psychological, which is deemed more effective, directive, and efficient. That is 1994. RBT was first called rational therapy, later rational emotive therapy, then changed to rational emotive behavior therapy. That is 1994. Theory, REBT is an active, directive, solution-oriented therapy which focuses on resolving emotional, cognitive, and behavioral problems in clients. RBT is based on the cognitive behavioral approach. Humans are both rational and irrational tendencies, which are biological and grow stronger as the individual matures. Irrational thoughts or images prevent goals attainment, lead to inner conflict, lead to more conflict with others, and poor mental health, example, anxiety, aggression, self-blame, etc., etc. Irrational thinking includes should, must, and demand, overgeneralizing and viewing events as terrible. Rational thoughts or images lead to goal attainment and more inner harmony. That is, rational beliefs reduce conflicts with others and improve mental health. RABT is based on the premise that it is not the events that take place in our lives that upset us. Rather, it is one's belief about the event which contribute to the unhealthy feelings and self-defeating behaviors such as becoming anxious, depressed, or enraged. RBT theory. The RBT model uses developmental theories such as Piaget with thought processes in children. It teaches the client to identify, evaluate, dispute, and act against his or her irrational, self-defeating beliefs, thus helping the client to not only feel better, but to get better. A basic principle of REBT when referring to children is that children are born with an innate capacity to think irrationally. Eldest 1994, to show that when unfortunate or unpleasant events occur in our lives, we can have a choice in making ourselves feel self-helpingly healthy. REBT aims to change irrational thinking to rational thinking. Rush 2006. Our REBT ABC framework. REBT employs the ABC framework depicted in the figure below to show the relationship between activating events, which is A, our beliefs about them, B, and the cognitive, emotional, or behavioral consequences of our beliefs, which is C. As you can see in the diagram, according to REBT, your reaction, which is C, is the result of your belief, which is B, and not caused directly by the event, that is A. Reference David. Next slide. REBT, there's these three basic. According to REBT, there are three common irrational beliefs. The three common irrational beliefs contain a demand, either about ourselves, other people, or the world in general. These beliefs are known as the three basic musts. 1. I must do well and win the approval of others for my performance, or else I am no good. This often leads to anxiety, depression, shame, and guilt. 2. Other people must treat me considerably fair and kindly, and in exactly the way I want them to treat me. If they don't, they are no good, and they deserve to be condemned and punished. This often leads to rage, passive aggression, and acts of violence. And third, I must get what I want when I want it, and I must not get what I don't want. It's terrible if I don't get what I want. I can't stand it. Next slide. The tree must continue. It is the demanding nature of the beliefs that causes the problem. Less demanding, more flexible beliefs lead to healthy emotions and helpful behaviors. The reference is Ross 2006. Most importantly of all, REBT aims that individuals have it within their power to change their beliefs and philosophies profoundly, and thereby to change radically their state of psychological health. Next slide. Goals of REBT. The goals are to assist people in 1. To help clients gain insight into their self-talk. To help clients assess their thoughts, beliefs, and behavior. To train clients in the principles of REBT. Importantly, REBT maintains that individuals have it within their powers to change their beliefs, challenge thinking and philosophies profoundly, and thereby to change radically their state of psychological health. Brian Zervans Erfurt and Young, 2010. Next slide, please. REBT techniques. REBT uses the following techniques, the goal of which are to help to identify irrational thinking, teach tools that can be used to change irrational thoughts. These are the cognitive techniques, the emotive techniques, and behavioral techniques. Those are the REB techniques by Eric 2001. The cognitive techniques. These aim at teaching clients how to deal with self-statements, so they no longer believe them and acquire a new philosophy based on reality. These include rational analysis, disputing irrational beliefs, changing one's language, reframing. Next slide. Rational analysis is the first step in REBT. It teaches the client how to uncover and dispute irrational beliefs. This is usually done at a first session. Then as the client grasps the concepts, we can give as homework. Disputing irrational beliefs. These are the disputing client's irrational beliefs. Example, client goes over a particular must, should, or ought until they no longer hold irrational thoughts or until it diminished in strength. Now, the change in language, imprecise language, is one cause of distorted thinking. Clients must replace must, should, and oughts with preferences. Now, reframing is a strategy for getting bad events into perspective. Is to reevaluate them as disappointing, concerning, uncomfortable versus awful or unbearing. Next slide. REBT emotive technique. REBT emotive technique helps clients change feelings about adversities and consequently behavioral change. Rational emotive imagery is a form of intense mental practice designed to establish new emotional patterns where clients imagine self or worst thing that could happen, unhealthy and upsetting feeling, and changing them to positive feeling. Role playing, clients rehearse certain behaviors to bring out what they feel in a certain situation, focusing on improving the rational beliefs related to unpleasant feeling. Now, shame attacking exercise aimed at increasing self-acceptance. Now, use of vigor, of force and vigor, it is using reverse role play when the therapist adopts client's belief and argues for it, while the client tries to convince the therapist that belief is dysfunctional. Next slide. RBT behavioral technique. This is a good way to check out and modify belief by ACT. The exposure involves clients entering fear situation that would normally avoid. Now, risk-taking purpose is to challenge beliefs that certain behaviors are too dangerous to risk when reason says, while the outcome is not guaranteed, they are worth the chance. And paradoxical behavior is when client wishes to change dysfunctional behavior, they are encouraged to behave in a way contradictory to the tendency. Practicing the new behavior will gradually internalize the habit. Now, postponing gratification, use a combat low frustration tolerance by deliberately delaying bad habits. Example, smoking. Thank you.
Okay. Using REBT to treat separation anxiety disorder. Slide. Therapists using REBT employ Piaget stages of development as a guide in setting age-appropriate clients, selecting age-appropriate clients. According to Piaget stages of cognitive development, a child's rational and logical reasoning abilities emerges at age 6 during the pre-operational stage. The onset of separation anxiety disorder begins at preschool. REBT is used with children as early as 6 years, and it is the first modern cognitively based therapy used for treatment of children and adolescents. Now, this case study shows separation anxiety disorder, SAD. It's a 10-year-old boy was referred to a psychiatrist and was presented with a history of anxiety in relation to sleeping away from home and being away from his mother. This occurred whether it was at a friend's home or a school camp. He expressed his anxiety as a fear that something would happen to his mother and that she would not be able to return to pick him up. Whether the separation had occurred or was anticipated, the patient and his mother complained that he would experience fear, worry, trembling, sweating, stomach churning, and crying. The patient's mother described him as very clingy during his preschool years, age 3 and 4, as he would not separate from his mother when she dropped him off at preschool. The patient would attach himself to his mother, and the preschool teachers would have to pry him off to create a physical separation. Between the ages of 4 and 9 years, the patient recalled having a repetitive nightmare in which his mother died and he was unable to help her. Slide. In 2003, grade 2, at age 7 years, the patient experienced homesickness while away at a school camp, which produced such a high level of distress that he vomited. The camp staff was unable to console his distress, that the parents were notified and advised to collect him. It was after this event that the parents sought professional help for their son. Now, the patient comes from a stable, middle-class, two-parent family environment and is otherwise a healthy child. He's a high achiever at school who enjoys playing basketball, tennis, and rugby, and enjoys interacting with adults and his peers. Other than the medical history noted above, the patient had no other clinical significant features. The boy in this case is presented with separation anxiety disorder. Separation anxiety disorder is a developmental, inappropriate, and excessive fear or anxiety concerning separation from those to whom the individual is attached. It is characterized by excessive anxiety associated associated with this child from the primary attachment figure, that's usually the parent, or from the home. Primary symptoms include somatic complaints, headaches, stomach aches, vomiting, excessive worry about potential harm to self and or other attachment figures, nightmares involving themes of separation. Slide.
Patricia.
Yeah.
Sorry to interrupt you. Elseda, could you please mute your mic? Getting a feedback on the YouTube. Complaint from the guys there.
Okay. Children may avoid situations, places that separate them from the attachment figures. Example, school, social events, or even sleeping alone. Children may resort to oppositional behavior, temper tantrums, screaming, pleading. Parental accommodations often strengthen separation anxiety response. Onset is most common during childhood, ages 7 to 12, with marked decline of onset during mid-adolescence and young adulthood. It is often associated with adjustment problems, eating disorders, and the onset and maintenance of depressive disorders. It is heterogeneous emotional problem. That means it's a mixture. The emotional problem is mixed. Slide. Separate and anxiety ensure what is normal and what is not. In early childhood, crying or tantrums or clinginess are healthy reactions to separation. Separation anxiety can begin before a child's first birthday and may pop up again and last until a child is 4 years old. But both the intensity level and timing of separation anxiety vary tremendously from child to child. A little worry over leaving mom or dad is normal, even when your child is older. You can ease your child's separation anxiety by staying patient and consistent and by gently but firmly setting limits. Some kids, however, experience separation anxiety that doesn't go away. Even when with a parent's best effort, these children experience a continuation of reoccurrence of intense separation anxiety during their elementary school years or beyond. Now, if separation anxiety is excessive enough to interfere with normal activities like school and friendship and lasts for months rather than days, it may be a sign of a larger problem, separation anxiety disorder. Slide. Some kids, however, experience separation anxiety that doesn't go away, even when with a parent's best effort. Didn't I read that? The children experience a continuation of recurrence or intense separation anxiety during their elementary school years or beyond. If separation anxiety is excessive enough to interfere with normal activities like school and friendship and lasts for months rather than days, it may be a sign of a larger problem, separation anxiety disorder, which I think I read already. Slide. Okay. Now, to confirm this diagnosis of separation anxiety disorder, we went to the DSM-5 classification, which states separation anxiety as developmentally inappropriate and excessive fear of anxiety concerning separation from those whom the individual is attached, as evidenced by at least 3 of the criteria. There are 8 criteria in this classification, but we will look at 4 that are related to the mentioned case, that case with a 10-year-old boy. So we're going to use criteria 1, which states recurrent excessive distress when anticipating or experiencing separation from home or from major attachment figures. Now, in the case stated that the 10-year-old boy was presented with a history of anxiety in relation to sleeping away from home and being away from the mother. Criteria 2 in the classification states a persistent and excessive worry about losing major attachment figures or about possible harm to them, such as illness, injury, disaster, or death. The case states that the boy had a fear that something would happen to his mother and that she would not be able to return to pick him up. Criteria 7 in the classification states repeated nightmares involving the theme of separation. The case states that the boy recalled having a repetitive nightmare in which his mother died and was unable to help her. And criteria 8 in the classification states repeated complaints of physical symptoms, headaches, stomach aches, nausea, vomiting, when separation or major attachment figures occurs or is anticipated. And the case stated that he vomited at school camp because of homesickness, and he experienced trembling, sweating, and stomach churning when separation occurred or was anticipated. Now, all of the listed criteria are there, and that is presented on the slide and for you to peruse. Next. Marshall.
Marshall, Kojo, please. Sir Kojo, could you go to the next slide, please?
Okay, I didn't know. Till next?
Yes, next slide. Okay, this part of the presentation will look at a step-by-step approach to, no, could you go forward? Go back.
Back?
I mean, back or forward, what is it now? Yes, go back up again. Right. Okay, so this part of, no, go back.
Forward.
All right, but, or forward, forward. Yes, forward. So this part of the presentation will look at a step-by-step treatment approach of separation anxiety disorder using rational emotive behavioral therapy. The therapy intervention was adopted from Brandt et al. From the book 35 Techniques a Client Should Know, which uses a 13-step approach to treatment, a 13-step approach of REBT to treating disorders. So during the first session, we may have about 6 or 8 sessions with a child treating using REBT and treating separation anxiety disorder. But during the first session, some type of anxiety instrument should be administered as a means of assessing the severity of the symptoms. And this anxiety instrument can be used as a pre- and a post-test measure. An example of an anxiety survey is seen below. We've given you 3 questions that could possibly be used using a rating scale of strongly disagree to strongly agree. So we look at the first question, which says, if something bad might happen, I might worry about it. And you ask the child, how would you rate your anxiety on a scale of 1 to 6? I have no control over my worrying. Question 2, how would you rate your anxiety on a scale of 1 to 6? You can move ahead, Sir Kojo. It is important to note that when working with children, therapists should proceed cautiously in developing a relationship before treating or before teaching REBT methods. And children must be seen as, or in terms of their treatment, different from adults, because children are not usually very trusting at the beginning, and so you have to take that time to what I would call warm up to them and to make them feel comfortable in your presence as a therapist. So as step number 2 could involve explain or asking the child what brought him or her to the counselor. And so an example of a question that the counselor could ask is, you're here in counseling because your mommy has concerns about you and how anxious and nervous you get when she has to leave you. And the therapist could also explain that, you know, you're a therapist and you want to just spend some time with him or her, and so he or she should feel free to express himself. The third step in that approach could be to agree on a target problem to discuss and goals for counseling. So even though this is a child, both the counselor and the counselee needs to agree on what the target problem is, and we need to come to some kind of consensus as to what are the goals for this counseling. And now, a goal for treatment, first of all, the target problem is to reduce the anxiety that develops when this child is separated from the attachment figure. And in the case study, we mentioned the parent or the mother. The goal of treatment is to develop skills to decrease the anxiety. And this could be done through a number of methods. I have their relaxation techniques. It could be deep breathing, whatever the technique is to assist the child in decreasing his or her anxiety. The fourth step could be assess the activated event. That is, it is important to determine the action that triggered the irrational belief. Why is the child so anxious? In this case, the irrational belief is, it could be many things. And so what the counselor wants to do is to help the client identify those irrational beliefs. And we are proposing here that you could use rational analysis technique, which is a cognitive technique. And so an example of how we could do this is to ask a question: what happens when your mother, what happens when you think your mother is leaving you? And what happens when your mother drops you off at school? And so this is intended to allow the child to know and to understand that there is an irrational belief. The fifth step could be to assess the consequence of the issue that resulted in seeking counseling. And the consequence may be behavioral, it could be emotional, or it could be cognitive. And in the case study, we are seeing behavioral consequences as well as emotional consequences. Step 6 could be to identify and assess a client's secondary emotional problems, if any. When we went through the case, or when I went through the case, I didn't necessarily see any secondary emotional problems. And so at this point, it is really to make an assessment if there is any. The 7th step could be to teach the client that beliefs behind A were directly related to C. And so what are the A's that we're talking about? A are the activating events, which are the actual events. And C are actually the consequences, such as the emotions that are spurred from those events. So you could demonstrate or explain to the child how the beliefs are connected to feelings and behavior. So for example, the therapist will point out to the child that he feels anxious because he believes that each time his mother leaves, it will be the last time that he will ever see her again, and that makes him very anxious and nervous, which leaves him feeling or starting to sweat for argument's sake. So we see where C, which is a consequence, is that the child gets anxious, which is the behavior or the emotion. And I'm not yet at C codure, but I'm just explaining that. We see where in the case study, the consequence, which is at C, is actually the anxiety. The child having been separated from his or her mother, the attachment figure. And a step, sorry, you could go forward, Kojo, to the 8th step. The 8th step could be to help the client dispute the irrational belief and facilitate a deeper understanding of the irrational, which is at B. So minimizing or managing anxious feelings by using techniques such as distraction, thought stopping, and rational emotive imagery. For example, the therapist could ask the child to close his or her eyes and imagine the worst feelings that he or she would have if his mother left him and went to work. And so the child may respond, oh, if my mother left me and went to work, my heart would stop beating and I would die. And then the therapist will ask the child if when his mother left him for school this morning, did he die? And so you're trying to dispute the irrational belief in this instance by saying, or giving the child an example that this morning when your mother left and dropped you off at school, you felt you were going to die, but you never actually died. So it is actually not a fact that you will die from her leaving you at school. The 9th step could be reframing by viewing a different angle. And this is a cognitive technique. So that, for example, the therapist will ask the child to close his or her eyes again and start thinking that when his mother leaves, he'll be happy and okay, like the other children at school. It is just trying to get the child to think about his irrational thoughts in another way. And the 10th step could be to help the client to develop a new philosophy that is more effective. That is, my mother is only leaving for a time and she will return. So it is allowing the child to stop thinking of the separation in a harmful way and start seeing it in a more positive light, which is like developing a new mentality or philosophy, which is to help the child reduce the anxiety. And the 11th step could be reframing by viewing at a different angle, which is also similar to 10, which is a cognitive technique. So the therapist will ask the child to close his or her eyes again and think that when his mother leaves, he will be happy and okay like the other children at school. Next slide, please. A 12th step could also be role playing, which is a behavioral technique, and this gives the child the opportunity to act out the situation which causes the anxiety and also act out new skills taught and change emotional self-statements. So it's two things that are happening here. You want the child to act out a situation that causes him or her to be actually anxious, and also to act out the new skills that will be taught, which could be the deep breathing or some technique that will help the child to change the emotional self-statements. And the 13th step could be an exposure technique where this can be used to allow the child to enter a feared situation he would normally avoid. Example, picturing his mother dropping him off at school and waving goodbye. And so the therapist would after which teach the child how to cope when placed in this anxious and fearful situation. Right. And the 14th step, I know I had said a 13th step approach, but I added a 14th step to this treatment process where you want to substitute words and phrases such as must and should to I would like to or I would prefer to. So, for example, the therapist could ask the client to write these words down on an index card with more rational statements written on the reverse of each card. For every must statement, the boy and the therapist might come up with 4 or 5 healthier replacement beliefs. So, example, we could replace my mother must be here for me to feel safe and secure to I prefer when my mother is here with me so I can feel safe and secured. So we're replacing must or should statements with I would prefer. So the purpose and the rationale for the use of REBT in treating separation anxiety disorder. So as counselors, we've decided to use rational emotive behavioral therapy as a therapy intervention method for separation anxiety disorder because it uses strategies like emotive and behavioral techniques. So in treating SAD, REBT shows the interrelation among thoughts, emotions, and behavior. Studies have compared rational emotive behavioral therapy to other forms of treatment and have found it to be an effective treatment for children suffering from various anxiety disorders. Anxiety problems are among the most commonly diagnosed mental and emotional problems to occur during childhood and adolescence. And so the primary focus of REBT is resolving an individual's behavioral and emotional problems. And so it is to identify and change the client's unrealistic thinking, and these are the irrational thoughts. Next slide, please. So continuing on the goals and objectives related to the intervention, it is to help the client understand that he has the ability to change his thoughts, which will lead to changes in his feelings, which in the case that we mentioned, it is the anxiety. One other goal is also to help the client understand what kinds of thoughts contribute to his anxious feelings. And one other goal could be to make the client more aware of his self-talk and internal dialogue, and particularly of his self-defeating beliefs, so that he will be able to think more rationally and self-helpingly. The client, or another goal of this treatment, is to help the client unconditionally accept self regardless of how well or not he performs. And this creates meaning and purpose in life. And the client eventually will adopt a self-helping philosophy. Next slide, please, Kojo. Sir Kojo, the next slide, please. I have three more goals related to the intervention, which are: one, to treat the client to evaluate his thinking, feeling, and behavior in order to experience more healthy emotions and fewer dysfunctions. The goal is also to show the client that whatever unpleasing, activating events occur in his life, he has a choice of making himself feel healthily and self-helpingly disappointed, frustrated, and annoyed, versus making him feel unhealthily and self-defeatingly horrified, terrified, panicked, depressed, self-hating, and self-pitying. It is also to teach the child the skills to use rational emotive behavioral principles, so he or she will act more functionally and be able to achieve his goals in life.
Okay, I will continue from here. But before I quote you can go to the next slide. Advantages and disadvantages of REBT. But before I start, I just want to give a quick summary of what we have been talking about so far. So we have said that the REBT is really a part of the cognitive behavioral approach, right? And we also talk about REBT being the basic tenet of it is that irrational thoughts affects emotions, emotions affect behavior. And so what Ellis was basically saying, because of our beliefs or schemas or philosophy or concept of life, that is what really affects our emotion, that affects our behavior. The approach or the technique builds their framework on cognitive development. So you find it's appropriate for a case such as this in children because it really is based on the different stages of cognitive development. And so Piaget looks at understanding. So for this particular case, the child is 10, and at 10 the child would be at the concrete operations according to Piaget. And for this child, he would be able to understand cause and effect. So we see that at this stage, the REBT technique is really based on the developmental theories, Piaget. We find that this particular technique is useful for this child, for this case. Now, continuing, also we want to, before I continue, just to give a summary in a nutshell, just to get to what we're talking about. Piaget or Ellis, in using REBT for children, is an approach that really helps to understand the nature of emotional and behavioral difficulties in children. So this is one of the rationales or the reason for using this approach. Now, advantages of REBT. The use of REBT with children can be extremely effective, and as I was saying to you, based on the framework of REBT, that it looks at developmental theories, cognitive development, so it is applicable to Victor. Somebody saying something? Somebody's commenting? No? So the second point is that the strength of REBT lies in its simplicity. REBT takes into consideration the developmental level of the individual, and which is an important part when dealing with children. Children may not view REBT as a form of psychotherapy due to its direct approach, didactic style, and it relies much on empiricism. So it's an approach that can be taught. And it's when we talk about the didactic style, we're looking at it's an approach that looks on the skills of teaching and learning. So it is not something that it can be applicable for the child. So the therapist will be using methods that are suited for children. The other slide, third slide, says where other models of therapy come across as mysterious and intimidating to children, REBT is exactly the opposite. This shows that with REBT, children will find it more comforting to let out their emotions and feelings, thus allowing greater communication between the therapist and the client. So based on the techniques that is used, you find that you can find age-appropriate techniques in working with children. As counselors, another advantage as we go along, as counselors incorporate understanding of the developmental neuroscience, learning styles, and the fundamentals of REBT, they can appropriately assist children to understand the process and the concept of thoughts and feelings. So it's not that it's the therapist in an age-appropriate manner will help the children to understand the fact how your thoughts are affecting their behavior. Another point is that a moral and or judgmental view is non-existent with REBT. So when we talk about, and this can help to explain one of the tenets of REBT, it doesn't look at the behavior defining the child, or in this case, the child. So because you did something bad, it doesn't mean that you are bad, right? So that is what one of the tenets of REBT. It states that it doesn't connect or blame the child as being bad because he did something bad. So continuing on the point, REBT therapists, on the other hand, would most likely assure the individual that even if he or she has committed a crime, it does not mean that he or she is a bad person. REBT, another point, REBT is hypothesized to exceed the effectiveness of other cognitive behavioral treatments by virtue of promoting unconditional self-acceptance and reducing secondary problems such as self-criticism about having problems. So what it is saying, even though you have problems, you should really love yourself irrespective of it. So teach the children how to love themselves. Continuing on the point, REBT has a low relapse rate compared to drug treatment in the absence of any accompanying therapy. The duration of REBT therapy is short, thus therapeutic goals are frequently achieved within 10 or 20 sessions. This shows that with the use of REBT, clients will undergo a shorter period of time to produce results as compared to other therapies. Another point, this means that with the use of REBT, children will gain greater self-esteem and increased confidence level as REBT helps them to think rationally and be more optimistic in their way of life. Go ahead with the slide, Kojo. So let us look at the flip side of it, the disadvantages. Now, one of the limitations they're saying is that REBT has all the limitations of a scientific approach to mental health. Thus, REBT has not clarified the mechanism involving various mental disorders So there's further research needs to be done on the technique. REBT is easy to practice poorly. It is from this that one immediate criticism suggests itself from the perspective of someone who takes a philosophical approach to life anyway. And inelegant REBT, and which we will talk about, could be profoundly irritating. The kind of conceptual disputing favored by REBT could easily meander off track into nuative, relatively far removed from the client's central concern, and the mental gymnastics required to keep client and therapist on the same track could easily eat up time better spent on more productive. Let me just stop and try to explain this a little bit better. A part of the REBT approach is to dispute irrational beliefs. So what they're saying, one of the disadvantages of REBT, you're trying to, in disputing, you're trying to show the client that what you really think really is not rational. And so you may find that in disputing that irrational thought, you may find that you spend a lot of time going round and round in circles, trying to convince the client or the child that what you're really feeling is really about what your belief is not really rational. So sometimes what they're saying that disputing those beliefs can go off on a tangent, and you miss the point of the whole technique. You can go ahead, hold on. So another disadvantage, the counselors and clients' estimations of relative importance could diverge rather profoundly, particularly if the client's outlook really does embody significant irrationality. So let us say that a child's mother met in an accident, and for this case, let us say that his mother met in an accident on his way to school, and from then he has formed this belief that, and it helped to trigger the separation anxiety, in that he believes that every time his mother leaves him, she's going to be in an accident. Now, the relative situation is that you cannot determine whether or not an accident will happen again. So, a part of the disadvantage is that you may find some real issues that may lead to the client thinking in a particular way, and you may find that it's difficult for you as a counselor to help them to diverge from that thinking. The next point looks at the need to match therapeutic approach with client preferences, even more pressing with REBT than with many other treatment types. In other words, it seems very important to adopt the REBT approach only with clients who truly are suitable, that is, children's ages 8 to 18. And as we said in the clientele of choice, REBT is not really suited for children below. Some research says 6, as low as 6, some say 7, some say 8. But it's not really practical for children below that age because of the stage of development. Another point, it can be counterproductive, although some clients specifically appreciate this kind of approach, and counselors who are unable or unwilling to provide the justification required are probably not right for those clients. Can go ahead. Another disadvantage, potential risk of misuse of the therapist's power by imposing ideas of what constitutes rational thinking. Clients may feel pressured to adopt goals and values the therapist says rather than acting within the framework. In another point, in REBT, clients could be exposed to what the therapist feels to be philosophically right, not necessarily what the client values or practices in his or her life. This may be a problem for the client as he or she may follow what the therapist deems to be right. Can continue. All right, so we're looking at the skills and the training requirements. The child therapist must have at least a master's degree in social work or counseling or a doctoral degree in psychology. Professional counselors, clinical social workers, and psychologists are all qualified to provide therapy to children. Children and young teens face emotional problems that are specific to age group, and child psychologists who will be working with them strive to help their patients with these particular issues. Experimentation with drugs and alcohol, depression, anxiety, sexual concerns, schoolwork and self-discipline, time management issues, and family life such as divorce or death all affect children differently than adults. So basically what we are saying is that you must be trained to deal with children. You must have some developmental training in knowing the different development of children, especially in cognitive development, to use the technique. Also, you have to bear in mind that working with children is different from working with adults, so you must be trained to use this approach. Continuing, child therapists have the expertise, as I was saying, to assess the depth of their patient's problem with them to develop coping skills and solutions. Clinical child psychologists focus on the diagnosis and treatment of mental disorders. They operate in a clinical setting, usually in a private practice, but sometimes in a hospital, school, and are trained to provide strategies for coping with specific disorders. A clinician must differentiate between the emotionally delayed child with continued separation anxiety and the child with early onset separation anxiety disorder. The two can be differentiated by the later age of onset, its persistence throughout childhood, and its general impact. Another point, the early separation anxiety disorder will usually not resolve without some kind of intervention or treatment. Those children with moderate to severe separation disorder warrant a referral to a child psychologist or a child psychologist. Now let us look at the variation of the technique. Now, the research will show that we have two basic variations. We have the general REBT and the elegant, and the general is also called inelegant REBT. Now, in the inelegant, it's used with clients with a wide range of concerns. Its focus is on reducing the consequences. It uses a variety of strategies. It has a more eclectic side. So you may find that they use a little CBT here, a little field therapy there, for the inelegant. It is not concerned with the client's philosophical concepts of self. So it's not about looking at how the clients view themselves. As I said before, it's really focused on reducing the consequences. It does not distinguish between healthy and unhealthy emotions. It seeks only to remove the symptoms. It places emphasis on self-esteem and not self-acceptance. It usually uses gradual desensitization in the process. Now looking at the elegant REBT, which is also called preferential REBT. This aims to make a philosophical change. So you want to change the whole scheme and the thought processes. It works at solving emotional problems first, then practical problems. It aims to change irrational beliefs to rational beliefs. It encourages clients, the technique encourages clients to rate their behaviors and not their self-worth. As I discussed before, because you did something bad, it doesn't mean that you're a bad person. It is viewed as the most effective form of REBT because it's honest, pragmatic, fewer philosophical difficulties. It employs several useful techniques, including cognitive assignment, reading assignment, listening assignments, imagery assignments, behavioral tasks, and emotive tasks. Go ahead. Now, we had some issues with finding a specific research that is linked to the Caribbean context. The closest we came to a research was one done in Canada about using our cognitive behavioral therapy with clients from English-speaking Caribbean countries, and that proved effective. However, REBT, further research did show that REBT is culturally diverse, and so we conclude that in the Caribbean context, because of its cultural diversity, it is applicable to the Caribbean or the Jamaican context. Can go ahead and good. So let us wrap up. Conclusion, few points. So we said before in the history that RBT was developed by Dr. Albert Ellis in 1955. We also said that it's an active directive, solution-oriented therapy, which focuses on resolving emotional, cognitive, and behavioral problems in clients. And one of the things that I must stress that with RBT is that it looks at emotions, not just cognition, but emotions, and how the thoughts affect the emotions, affect the behavior. It focuses on evaluating irrational beliefs. The theory states that even though people are determined by genetics or environment, they can change. It focuses on techniques such as the cognitive, the emotive, the behavioral, rather than insights. It teaches people how to change. It encourages people to accept their limitations while working on self-change. Go ahead, Kobe. Anxiety problems are among the most commonly, this is something we discussed, commonly diagnosed mental and emotional problems to occur during childhood and adolescence. And the research suggests that if it is left untreated, many children will struggle with anxiety later in life. REBT teaches the client to identify, evaluate, dispute, and act against his or her irrational self-defeating beliefs, thus helping the client to not only feel better, but to actually get better. The goal of this therapy is to enable the individual to lead a more fulfilling and happier life. Helping clients understand what kinds of thoughts contribute to anxious feelings is also important. Is also an important component of the process. We want to show just a 3-minute video of the technique.
I'm gonna attempt to show it on YouTube. Okay. So I'm gonna try doing it. And it's gonna be shown here. I'm gonna copy it to the other student. Does everybody know to click on the YouTube icon in your chat inside of the chat here? It's on the left side. You move your mouse to the left side and you click on a red icon that looks like a play to open YouTube. So I'm gonna try and put it in YouTube now so that everybody in the chat can watch it, and I'll copy it to the rest outside and on YouTube proper. Everybody in the chat, can you?
Dr. Mark, perhaps you want to comment in the interim?
I'm listening to it. Are we
Oh,
done?
you're listening. Oh, there's something. Oh, I wasn't seeing it, so I was wondering. Oh no, Dr. Mark, I thought it wasn't up as yet. I'm so sorry. Guess because I'm not seeing it.
Okay, that's enough. Okay, that's the video. Go ahead, Marshall.
Sorry, what was that, Coach?
Go ahead,
I should.
group 3. Continue. I'm gonna have to bring up back the presentation because I had to cut from it. Okay, that's it then?
Yes, that's it.
Yes, that's it. Thank you very much, colleagues and Dr. Matt, and thank you very much, Kojo, for your assistance. They're all right.
Well done, group.
Thank you, Robert.
I like the video. I think I'll go and find it and use it at some point in time. Dr. Mark, I see you moving, talking, but your mic is mute, Dr. Mark.
Mic is muted.
Sorry about that. I'm saying that it was an excellent presentation, the way they put it together for a 10-year-old using it's a very difficult, what I call an adult treatment approach, but the way they use it for a 10-year-old in terms of assessment, determining the level of anxiety, and how they used it for a 10-year-old was excellent. Anybody had any questions to them before we go to group 4? Any questions? Any questions? If there are no questions, thank you very much, Group 3, for a well put together presentation. In fact, all the presentations so far were very well researched and presented. Thanks again. All right, so at this time, then, we're going to be loading on Group 4 to complete this marathon of a course. And Mr. Barr and company, you're on the floor, please. And while you do that, I need to excuse myself. I'm going to get some more water. So I'll be back in a moment.
So, Dr. Mark, should we kick off without you or wait on you?
Wait on her.
Alison? Elcedo?
She can't hear you now. She can't hear you now.
So that means she's not able to present then.
No, somebody has to go read her part.
That's what we're trying to find out. Hello?
Kojo, why is it that she's not able to?
Her computer has a problem.
Cool.
Nadia, you all seen the presentation?
Huh?
You seen the presentation?
Yes, I'm seeing it.
Okay.
Where am I getting an echo?
Other people's mic on.
Oh, guys, the people who were in YouTube, well, they were having a problem hearing during the presentation. So, even for the person who was presenting, for those persons who are not on the floor, they could mute their mics so that they have less feedback on the YouTube. Anybody heard me?
Marshall, you will have to mute her mic. Or I'll do it for her.
Alison, are you there? Alison?
Okay, you're fine now.
Yes.
Wait, you just wake.
No.
Do 10 push-ups and run, come back. Alison, you can't show your video while you're presenting.
What video?
I don't hear you.
What video?
Your webcam.
Alison.
Yeah.
Variation, please.
Variation?
Yes.
Oh, she's variation.
Oh, okay.
Okay, we're ready. Group 4.
Nadia.
Yes.
Ethical and cultural. I'll do the rest.
Ethical and cultural.
Yeah, I'll do the rest.
Alright.
A pleasant evening, ladies and gentlemen. Dr. Mac, all the way in Canada there. We are Group 4, and our presenters are Nadia, Elseda, Alison, and myself. And we will be presenting on conduct disorder using the treatment of CBT. We'll start with the introduction, and we will process in that order. Alison, over to you.
Good evening, everybody. As my colleague stated, we'll be looking at the cognitive behavioral therapy and how it can be used to treat conduct disorder. So we can look at the description of conduct disorder as per the American Psychiatric Association. And they described it as a repetitive and persistent pattern of behavior that violates others' rights, which also includes societal norms and regulations. Now, children that are diagnosed with disorder are often aggressive, disruptive, and deceptive in their behavior, and they're sometimes described as being bad or delinquent. Now, the symptoms that a child with conduct disorder will display would be normally seen in the home, in the community, and at school. And those behaviors include, and there are many other behaviors that can fall into this category, but behaviors such as bullying, even including of the sexual type, raping others, conning, stealing, and these behaviors may show up as early as 5 or 6 years of age. However, onset of these symptoms don't normally occur until the early teenage years. Now, over time, the symptoms of conduct disorder intensifies, and it also creates behavior patterns that make it a lot more difficult to stop or control as the child ages. So more often than not, as the child is getting older, the behavior intensifies, and therefore there's less ability to control that behavior. Now, Conduct disorder can also lead to other diagnoses of mental illnesses, and it can lead to early death and drug misuse. Now, because of this, it is necessary for children who are diagnosed with conduct disorder to receive thorough clinical intervention that is sound and well researched and put together for each individual child. If left untreated, conduct disorder can lead to further issues in adulthood, such as antisocial personality disorder, and that can also lead to incarceration, death, other criminal and violent behaviors. Now, in treating children with conduct disorder, the best therapeutic approach needs to be selected by clinicians, and these clinicians will have to research and do their case conceptualizations so that they can make the case, make it specific for the child that they're treating. Now, there are a number of methods that can be used, and those include, as you can see, psychotherapy, behavioral parent training, cognitive behavioral and social skills training, medication, and family therapy, also parent management training. Now, this presentation will be geared towards identifying the child who is presented with symptoms of conduct disorder, and then we'll be using some of the techniques of cognitive behavioral therapy to treat that disorder. Cognitive behavioral therapy is being used because it is designed to assist counselors in helping their clients to reshape the child's thinking patterns. It also helps us to provide the child with problem-solving skills, improve their communication, and also help them to control impulses and their anger. Research has also shown that this is a very effective treatment, which involves network of influences such as the family, school, and peer group. So even though there might be individual therapy, it also can include the family and other persons around the child to help them with this disorder. Now, as we continue, we're going to be looking at the etiology of conduct disorder, and we will ask Nordia to get into that so that we can delve further into what conduct disorder is.
Thank you, Alison, and remember to mute your mic, please. Okay, no single factor is said to have contributed to conduct disorder in children. Instead, a number of factors have played a role in the development of disorder, and some of these factors include parental factors, sociocultural factors, psychological factors, neurobiological factors, neurologic factors, child abuse and maltreatment, video games, and comorbid. And I'll run through some of those very quickly. So for parental factors, parenting styles that includes punitive and harsh parenting, and of course that would include verbal aggression. It does play a role in children developing maladaptive aggressive behaviors, right? As relates to divorce, as was earlier in the class, it's not really the divorce itself, but is the relationship between the parents. So what this person is saying is that is the hostility and bitterness and resentment that is between the parents that plays a major role in contributing to the child developing conduct disorder. Other parental factors include parental psychopathology. So what it is saying is that parents who have mental illnesses, for example, psychotic disorders, this can result in the child developing conduct disorder. Negligence, again, we discussed that is a part of the parenting style. If the parenting style is a negligent parenting style, then you realize that maybe other relatives or other caregivers may have to be involved in the child rearing process, and this can trigger maladaptive behavioral patterns. Child abuse also, for parents who were abused themselves, they may be negligent towards their child because they're preoccupied getting their own personal needs met, and this may also be a contributing factor. Next slide. As it relates to socio-cultural factors, we had learned in class that children who are from families that are socio-economically deprived, they're at higher risk of developing psychopathology. In this case, they're at higher risk of developing conduct disorder. And it is also true for children who grew up in the urban areas, because what happens is that research has shown that for children of parents who are unemployed or parents who are absent, or if there's a lack of social network and they don't have the opportunity to participate actively in their community, that can be a predictor of the maladaptive behavior. Continue. In regards to children who are from the urban areas, what research is saying is that in the urban areas, there's increased rate of prevalence of substance use, and this can play a role in the development of conduct disorder. In terms of alcohol, it's not alcohol itself that really contributes or causes the disorder, but it's the risk that is associated with it, right? For example, the intoxication when you drink, it can aggravate the symptoms of conduct disorder. Next slide. Next slide. Psychological factors. Children who are brought up in chaotic and negligent conditions, they tend to express poor regulation of emotions such as anger, sadness, and frustration. And in these children, poor modeling of impulse control and deficiencies in meeting their needs that contribute to a poorly developed sense of empathy. For neurobiologic factors, not much study is available in that regard, but their studies have shown that in many children with conduct disorder, they may have comorbid conditions such as ADHD. Continuing on the biologic factors, low levels of plasma dopamine, B-idrolax, I'm not sure about the pronunciation, that is also responsible for converting dopamine to norepinephrine, and they're saying that this does play a role, the low levels does play a role in a child developing conduct disorder. And as a matter of fact, some studies were conducted and among juvenile offenders who were conduct disordered, and it was noted that high serotonin levels were present in their blood. Next slide. For neurologic factors, we look at the resting frontal brain electric activity, and they're saying that emotional intelligence and conduct was studied to determine the relationship between the resting frontal brain electric activity, emotional intelligence and aggression, and rule breaking among 10-year-olds. And the findings have revealed that the frontal resting brain electrical activities, it reflects the ability to regulate emotionality. So what this is basically saying is that children with higher reported externalizing behaviors and had significantly greater right frontal EEG activity during rest than those children who had little or no aggressive behavior. In terms of boys, while in the study that was conducted in Canada, boys showed lower level of emotional intelligence and greater aggressive behavior than girls. However, there was no evidence of a relationship between emotional intelligence pattern and pattern of the said frontal EEG activation study that was alluded earlier. As it relates to child abuse and maltreatment, for children who are chronically exposed to violence, especially those who were repeatedly abused, whether sexually or physically, starting at an early age, these children are at a higher risk of developing aggressive behaviors. Also, for children who are exposed to parents or caregivers who themselves were victims of abuse or violence, they tend to display disruptive and aggressive behaviors. Children and adolescents who are severely abused tend to be high vigilant in the sense that, as a matter of fact, in some cases, some of these same children who were severely abused, they may tend to interpret benign situation as a direct threat to them, and this results in them responding with violence. However, not in all cases will the physical behavior expressed by children suggest or indicate a conduct disorder. However, if these children have a pattern of high vigilance and response, then it is likely that they will violate the right of others. For comorbid factors, I had mentioned earlier about the ADHD, and in other cases, damage to the central nervous system, that's the CNS, and early extremities in temperament, those are predisposing factors of the said disorder. All right, longitudinal studies on temperament have shown that many deviations in behavior patterns are initially a direct response to a poor fit between a child's temperament and emotional needs on one hand, while on the other hand, parental attitudes and child rearing practices have contributed to the disorder. In terms of violent video games, I'm sure many of us can attest to the fact that over the past couple of years, video games have been very popular in homes. But what research is saying is that when children are exposed to the aggression that is shown in or is present in the violent video games, what it does, it causes physiologic arousal and aggressive behavior, right? And this is an indicator that the degree to which a child is exposed to these violent video games do have a bearing on that child's preoccupation with violent things. Now we'll ask Robert to do the history. No, sorry. Alison will continue with the DSM-5 criteria for conduct disorder.
Alright, hi again, guys. Now, the DSM-5 describes the criteria for conduct disorder as a repetitive and persistent pattern of behavior in which the basic rights of others and major age-appropriate societal norms or rules are violated, as manifested by the presence of at least 3 of the following 15 criteria, and this is seen in the last 12 months from the categories that are below, with at least 1 criterion present in the last 6 months. Now, under the criteria of aggression to people and animals, children with conduct disorder often bullies, threatens, or intimidate others. They often initiate physical fights, have used a weapon that cause serious physical harm to others, and that can include the bat or broken bottle or a gun. They have been physically cruel to people, cruel to animals, have stolen while confronting a victim, or has forced someone into sexual activity. Now, under destruction of property, they have deliberately engaged in fast setting with the intention of causing serious damage, or deliberately destroying another person's property, which would include everything else other than fire setting. For deceitfulness or theft, they've broken into someone else's house, building, or a car, often lies to obtain goods or favors in order to avoid obligation, or they've stolen items of non-trivial value without confronting a victim. For example, there will be shoplifting that would include stealing without breaking or entering, and they could also engage in forgery. Under serious violation of rules, they often stay out at night despite parental prohibitions, and this is often seen occurring before the age of 13. And they have run away from home and stayed overnight at least twice while living in the parental or a parental surrogate home, or once without returning for a lengthy period of time. To continue, they are often truant from school, and this is seen occurring before the age of 13. The disturbance in the behavior causes clinically significant impairment in social, academic, or occupational functioning. However, if the individual is 18 years or older, and the criteria are not met for antisocial personality disorder, they would be seen as having conduct disorder. Now, you can specify whether it is a childhood onset type, and this is seen in individuals who show at least one symptom characteristic of conduct disorder before the age of 10. You have adolescent onset type, and this is seen, they show no symptoms characteristic of conduct disorder before the age of 10, but they've seen it after. And you have the unspecified onset for diagnosis of conduct disorder that is met, but it's not sufficient information to determine whether or not the first symptom occurred before or after 10 years of age. You can also specify if there's limited pro-social emotions, lack of remorse or guilt, lack of empathy, and they're unconcerned about their performance, they're shallow. You can also determine whether it is the severity of it, whether it is mild, moderate, or severe. And now we'd look at the developmental concerns and ask Robert to take over here.
Thank you so much. There are several developmental considerations that has to be given when you consider a child in relation to a conduct disorder. The disturbance in the behavior causes clinical significant impairment in social, academical, and occupational functioning. The onset of the disorder may occur from as early as the preschool years. However, the first symptom tend to emerge during the period which is considered the middle childhood through to the middle adolescent. The course of the disorder varies in majority of individuals, and it usually remits in the adult years. Next slide. Antisocial behavior are clearly rooted in childhood. As stated before, a child cannot be diagnosed with antisocial disorder until that child reaches the age of 18 or over. There are two main developmental routes for this particular disorder. One is an early onset in childhood and a post-pubertal, or that word there, in terms of adolescent onset. These varies in etiology, natural causes, compounding features, prognosis, and treatment needed. The prevalence rate normally is from 2% and then 10%, and is consistent across countries that varies in race and ethnicity, which says that conduct disorder is not just specific to North America. It happens right across the world. Next slide. The neuropsychological defects and the family adversity predisposes the early starter to a life of antisocial behavior. So psychologically, the child is at a disadvantage, and the family structure also predisposes that individual. Aggressive behaviors are normally crystallized around age 8, both stable and characteristic the cause of conduct disorder. CBT techniques require that the therapist have to some degree an insight on the verbal ability of the client. Next slide. Treatment outcomes have indicated that adolescents who are older have clearly benefits from these particular techniques in terms of their communication and problem solving skills, anger management, and impulse control, whereas younger children We rely more on environmental interventions, for example, behavior modification and modeling. The role of the parent in treating with children is greater than those of the older children. So the younger children, where the parents are concerned, they are at a better advantage than the older children. Therefore, the therapist should mainly focus on helping the parents, teaching them the skills in relation to what will help the child. Next. Next. So we now move into, go back, Mr. Naomi, please. What is behavioral therapy? It is a problem-focused approach helping people to identify and change their dysfunctional belief, thoughts, and patterns of behavior that contribute to their problems. Next slide. Cognitive therapy concentrates on thought, the assumption, and belief. People are encouraged to recognize and to change faulty, maladaptive thinking patterns. Cognitive therapy helps the clients to take control over inappropriate, repetitive thoughts and often feed or trigger various presenting problems. The history of CBT technique was developed by Dr. Beck in the 1960s while he was a psychiatrist at the University of Pennsylvania. Beck's approach became known for its most effectiveness in treatment of depression. Having studied and practiced psychoanalysis, Dr. Beck designed and carried out several experiments and tests of psychoanalytic concept of depression. So he pretty much developed the concept. CBT is generally classified as psychotherapy, and there are several approaches that fall under this kind of classification. You have the rational emotive behavior therapy, the cognitive therapy, the rational behavior therapy, the rational living therapy, the schema focused therapy, and the didactical behavior therapy. Each approach have its own developmental history, and the following is accepted accounting history of CBT. The irrational emotive was pretty much the first one that he developed in the mid-1950s. Ellis also developed and popularized the ABC model, which was mentioned before by Group 3 of emotions, and later modified it to ABCDE approach in the 1990s. Next slide. It is rooted both in cognitive and behavioral. All behavior is either learned or influenced by environmental factors. What is important for individuals is not their experience in itself, but the meaning that we attach to these experiences, and this is supported by empirical evidence. There are three levels of cognitive structure: the schema, the conditional belief, and the automatic thoughts. They are there. For interest of time, we'll move on. CBT in therapy is collaborative. It is structured and finite. For the collaborative, it is a client-centered approach. For the structured, is maintain and present problem, and they are addressed in a systematic manner. So it's 1, 2, 3, and not 1, 5, 10. It is structured. It is finite. It has a specific amount of session. Normally, we have 10 sessions in a treatment plan, but it all depends on what are the presenting problems and how we plan to treat those problems. We'll now ask Nordia to continue with the variations.
Alison.
Is Alison? Hello? Yeah. You're going ahead?
Yeah.
Go ahead.
All right, variations to CBT. According to Scott, now the following are intervention principles of cognitive behavioral therapy. You can engage the family. You can select a treatment strategy to use and decide who should deliver it. You can also treat comorbid conditions. You can develop the client's strengths, promote social and scholastic learning. You can use guidelines for treatment, and you can treat the child in his or her own natural environment. Now, there are four key strategies to cognitive behavioral therapy. You have the behavior management, modeling, social problem solving, and cognitive restructuring, and you also have self-management. All right, now we're going to look at variation of cognitive behavioral therapy, which would include rational emotive behavior therapy, which was discussed with the group before us. You have the schema-focused cognitive therapy, and you have dialectical behavior therapy. Rational emotive behavior therapy, as discussed before, was developed by Albert Ellis. In the interest of time, we will not go through all of those. The information is on the slides, and we also had discussed this before, so we're going to move on. The schema-focused cognitive therapy is an expanded variation of CBT, and it focuses on lifelong patterns, effective change techniques, and the therapeutic relationship. And it places a lot of emphasis on the unlimited reparenting. Now, the core principle of this method is early maladaptive schemas that are persistent patterns of psychological responses that dictate how the world is perceived and how the perception of the world and their experiences are understood, and the behaviors and emotions that come as a result of all of those. There is also the clusters of schemas that function together. The four main ones are the healthy, damaged child, coping, and dysfunctional parent modes. The technique was developed by Dr. Young and is executed in 3 stages, which we can see below. Assessment phase, where the schemas are identified. The experiential stage, where the client learns to identify the schemas and how they function within their daily lives. And you also have the behavioral change phase, where the client actively replaces those negative, pervasive thoughts and behaviors, and they have to replace them with healthy ones. Whatever you take out, you have to replace. Now, Dr. Young also suggested that emotive techniques are used so that the client can fully express their feelings, of which there are several variations, and that can also include using role-playing. Another variation is letter writing, so that the client can express themselves so that there's no limitation, there's no influence of other persons or anybody else except for the person who will be who is writing the letter. They don't have to give it to the person who the letter is to. It is just to allow for the person to express themselves. This is useful, especially if the person is more expressive in writing than they are verbally. To continue with the dialectical behavior therapy, it is an integration of opposites, with the primary dialectic in DBT being acceptance and then change. Now, mindfulness, distress tolerance, interpersonal effectiveness, and emotion regulation are 4 skills that are taught in the following stages. Stage 1, achieving behavioral control. 2, full emotional experiencing. 3, lead a life of ordinary happiness and unhappiness. And 4, the ongoing capacity for experiencing joy and freedom. Now, all of these, they can be used to treat children. However, you can see that the counselor will definitely have to pay attention to what these methods and variations to CBT are and how to actually implement it for a child. Now, Strength building and self-statements is another technique that is used in the dialectic behavior therapy. And some of those examples are, what is the worst that can happen? And based on my experience and not my emotion, how likely is it that they will happen? The second one, feelings are sometimes painful, but they are time limited. 3, it will get easier each time I practice. Another technique is to stay strong when painful emotion tends to be controlling you. And strong stands for sleep as much as you need, take medications prescribed by your doctor, or resist using street drugs or alcohol. Once a day, do something that makes you feel in control. Nutrition, eating a balanced diet, and getting exercise. This is just a fun way to help teenagers and children to remember how to go through the day and keep strong. To continue, we have techniques or strategies that can be used within CBT, which are encouragement and compliments, and that is a form of positive reinforcement to increase a particular desired behavior. 2, you have contingency contracting, which is used to promote new behaviors by creating a contingency plan that must be met in order to receive a reward. And these can be used by encouraging parents to use a contingency contract with children that detail how the privileges or rewards will be earned or they'll be lost. You can also have point charts and token economies, which are used for younger children, and those can be used to shape and reward positive behaviors by allowing them to accumulate points that they can trade for privileges or treats at the end of a time period. However, the rewards have to be motivating for each child. So you might have 5 children, and each of those children you need to use the point charts and token economies, but because they have different personalities, you might need to have different rewards to find what is motivating for one child in particular. You can also have psychoeducation, and that is one of the hallmarks of CBT, and it involves teaching the clients psychological and rational relational principles about their problems and how best to solve them. There are also 3 categories of psychoeducation. You have problem-oriented, that involves providing the client with information about his or her diagnosis or situation, explaining to them what ADHD is, what it means, what conduct disorder is, what it means, how it can be treated, etc. You also have change-oriented. That involves providing the client with information on how to go about reducing the symptoms, problem symptoms that they're experiencing. Whatever experiencing that symptoms they're experiencing, for each person will go through how it can be changed. You also have bibliotherapy, which will be assigning readings that will be motivating and instructional for dealing with the presenting problem. You can also use, for example, self-help books or psychology books. You can also have cinema therapy, which is a very interesting one that assists, you can assign the client to watching a movie that will speak to the client, and this can be particularly helpful for younger kids. If you have a short cartoon film that can help them to see it in a fun and engaging way, that can be used for them. All right, we'll have Nordia quickly go through the case study of Junior McDonald, who we will be treating with CBT and some of the variations we just looked at.
Thank you, Alison. Junior McDonald, who is about to turn 10 years old and is in 5th grade, was referred for counseling by his school teacher, Mrs. Johnson. The referral letter from Mrs. Johnson stated that in the last 6 months, Junior has been frequently absent from school, and this has resulted in his grades falling significantly. However, Junior doesn't seem to be bothered by his poor academic performance. An appointment was made for Junior's parents and his teacher to attend a counseling session. During the intake interview, the counselor was informed that Junior's mother died 2 years ago. He then went to live with his father, John MacDonald, and his stepmother, Diane French, a little over a year ago. Diane is a housewife, while John works as a handyman on a plant in the town area where he is paid minimum wage. Both John and Diane reported that in the last 12 months they noticed a change in Juna's behavior pattern. During that time, they reported that they had about 6 cats who died because Juna catches them on fire. Diane said she recalled that every time Juna's cousin Sally visits, Juna would grab her doll and break off its head. Mrs. Johnson, that's Juna's teacher, also reported that she noticed changes in Juna's behavior in the last 12 months. According to her, he bullies the first-year graders and would often see taking away their lunch money. She also informed that during class he always finds a way to initiate a fight with a classmate. While they were in the sessions and the session with the parents and the teacher and the counselor, Juna's father received a call from the counseling session by the office admin assistant. He left for about 10 minutes, and when he returned, he had an angry look on his face. He then shared that Juna was supposed to wait on him and Diane in the reception area, but instead he went outside and was fighting with another child who was waiting by the fish tank for his parents. And he was also stating that wherever Juna goes, Juna gives trouble. Next slide. Alright, so based on the interview, so we're going to do a little evaluation. We're going to do an evaluation. Based on the interview with Juna's parents and teachers, we saw that Juna has behavioral problems consistent with F91.1 conduct disorder, childhood onset type, concern about performance, and it is severe. The indicators consistent with this diagnosis are impairment in academic functioning, that's consistent with criterion B from the DSM, truancy from school, consistent with criterion A15, bullying of the first graders and taking away their lunch money, criterion A1 and 6, initiating fights with his classmates, criterion A2, physically assaulting another child, criterion A4, breaking off his cousin's doll head, criterion A9, setting the cat afire, criterion A5. We noticed that these started before age 10. Also, his maladaptive behavior began in the last 12 months, and as recently as 6 months ago, he became a truant from school. And he doesn't seem to be bothered by his falling grades. So what we're saying is that all of these are evidence that he has met the criteria discussed earlier. All right, as it relates to the purpose and rationale for using CBT, child-focused CBT has been tested in 31 control studies, and therefore it is the most widely researched intervention for child conduct problems. Not only that, but it also has demonstrated positive effects across a wide range of ages, diverse racial and ethnic groups, and children who demonstrated elevated levels of conduct disorder, including those who met the criteria for oppositional defiant disorder and conduct disorder. A number of trials have revealed positive treatment effects when the participants have comorbid conditions in addition to their conduct problems. Also, when tested in research, CBT has proven effective in correctional settings, residential treatment facilities, and inpatient psychiatric units and in schools. Not only that, but it targets the emotional, behavioral, and cognitive skills deficits that are germane to conduct problems. In the case of Juna MacDonald, we will use psychoeducation because it is a hallmark of CBT. And so Juna's teacher, his father and stepmother will be taught the psychological and relational principles about his conduct disorder and strategies that can be employed to address this his maladaptive behaviors. Also, contingency contracting and encouragement and compliments will be used as behavior modification strategies for junior. All right. And we chose these because we realized that the intervention for children ages 5 to 11, according to Bart and Scott 2002, should focus on behavior management and on modeling. As it relates to goals and objectives, I think that is Alison.
All right, everybody. We'll try to come to do this as fast as possible. Now, goals and objectives for using cognitive behavioral therapy with children with conduct disorder. As was mentioned before, primarily to reshape the child's thinking about their environment, themselves, and their behavior. Right? Now, to focus on 4 of the key strategies using behavior management, modeling, social problem solving, and cognitive restructuring and self-management. Goals and objectives for therapy depend on each client and the type and severity of the behavioral problems. Now, for example, they will have the goal of managing frustration in a positive way. The objectives that we could use for junior: take deep breaths at least 6 out of 10 times in order to calm down. Now, each goal should be time sensitive, so you're giving it a time frame so that that can be completed, and each objective should also be measurable so that the child is able to acknowledge how much they have grown and how much they have learned, and also that will help the counselor to know how the counseling session has been progressing. So also we can have an objective of counting to 50 at least 3 times when beginning to feel frustrated or annoyed. Next one. All right.
That's Robert.
Oh, Robert?
Yeah.
Are the methods of assessment. 1, there is observational, and there is also a clinical interview, after which we can use to confirm with the DSM diagnosis that we are arriving at a pretty much a good assessment. Tools for assessing disorder, such as a child behavior checklist, where the child can pretty much fill out this checklist along with the therapist or clinician. This was developed primarily for children between the ages of 6 to 18. We can also do a Goodsman strength and difficulty questionnaire, also to assess these kinds of behaviors that the child may be demonstrating, to see whether or not the child meets the requirements for conduct disorder. We will now ask Nadia to do the advantages.
All right.
And
thanks. I will just list the advantages. I won't explain them. There are a number of advantages of the cognitive behavioral therapy approach. 1, it is very instructive, and that's straightforward. 2, the therapies are shorter terms. You won't have persons being in therapy for 2 years, 3 years, or a year. Next slide. The CBT, it emphasizes getting better rather than feeling better. Next, cognitive behavioral therapies are cross-cultural, so it can be applied to the Jamaican context, to the American context and other contexts. They're structured, so they follow a specific pattern. All right, the therapy sessions follow a specific pattern, and they can be researched. We had mentioned earlier that CBT is one of the most widely researched approach. All right, and it's here again, and the therapies are adaptive. All right, so right. There's some other advantages. Sorry. Child-focused CBT has been tested in 31 control studies. I just mentioned that. It's one of the most widely used research intervention for child conduct problems. And also, it has demonstrated positive effects across a wide range of ages, diverse racial and ethnic groups. All right, that, cross-cultural again. Next slide. Disadvantages, two were identified, right? When CBT is used in group format with children who has conduct disorder, it may lead to those children forming relationship with other deviant children in the group to gain social reinforcement from those peers for their deviant behavior. Sorry. While it has proven to be effective in children, not all the approaches might be age appropriate or can be used for younger children. Therefore, the therapist must be mindful that for the younger children, it will be more difficult to implement the cognitive strategies directly. And so the therapist needs to ensure that the techniques are simple and specific. Also, if the child is not developed properly in terms of their mental ability, it might be difficult to use CBT strategies with them. Sorry, no, ask Robert to do this skill and training requirements.
Right, so the therapist must have certain skills and training in relation to treating with this particular disorder. For example, the therapist must be able to demonstrate some amount of attending skills, questioning and probing skills, and also empathy. The therapist should have a sound knowledge of the Child Care and Protection Act 2004, and this is a policy within the Jamaican context. Right? If the council is operating outside of the remit of Jamaica, the council should also be aware of any policies relating to children, because that will also affect how the individual treat with the child care. The therapist should also have a sound knowledge of the laws that govern the country in which he or she operates. The therapist should possess at least a first degree, which is a bachelor, or in counseling or in any related field. Next slide. The therapist should attend and participate continuously in specialized or speciality in terms of workshop, which concentrates on intensive training in the treatment and specific disorders or populations. The therapist should be able to counsel using a multicultural approach. Should not be biased in relation to who they want to treat. The therapist should be knowledgeable of techniques that are developmental and gender sensitive. The therapist should be skilled in using Socratic questioning. The therapist should be knowledgeable of case conceptualization process and treatment planning. For example, introduction of client, background information, etc. The therapist should possess skills of being able to, someone is calling me, being able to access the barriers and changes, emotional deregulation, for example, training in and knowledge of the various CBT techniques, etc., etc. Next slide. A supervision and consultation program that provides individual therapists. What we're saying that is that the therapist should have someone that they report to, so that they can be supervised and have that kind of interaction with their peers, so that they can bounce ideas off. No man is an island, no man stands alone. Knowledgeable about the APA codes of ethics and the ethical principles that governs this particular profession. Do no harm to our clients. The therapist should be able to integrate approaches that involve the child, the family, the school, and community. Next slide. We will now ask Alison to take over the interventions for the case.
All right. Every treatment plan should have at least 3 phases of treatment. The initial phase, working phase, and the closing phase or final phase. Now, the treatment plan for junior will therefore follow along with those 3 phases. For the initial phase, we'd first develop a working therapeutic relationship with junior and his parents. And in connecting with junior based on his personality, based on who he is, we can also use humor to connect with him, just to get down onto his level. We can assess the dynamics in the home and the school and their respective communities. We would define and obtain the family's agreement on the treatment goals and identify needed referrals and other needs the client may have. The working phase, during that phase of treatment, we will, or the therapist will ensure that they will monitor the working alliance with the client and assess whether or not that working alliance is still strong, and also monitor the client's progress. And here we have some further treatment goals and objectives that can be used for treating junior. Goal, as we had mentioned before, the managing of his frustration in a positive way. And we'll skip down to the strategy. Deep breathing exercises that can be done while experiencing frustration at home as well as at school. Another goal, express anger in a non-violent way. An objective is to communicate verbally with non-offensive words how you feel and why you feel that way. The strategy is to build up social problem-solving skills and provide a worksheet for junior in the session that will allow him to identify and describe his feelings and then recognize the consequences and other healthier ways of dealing with those problems or those emotions. Be present at school. This one is directly towards his truancy. Be present at school and improve academic performance. Objective, attend 6 out of 8 classes per day. Another one, participate in 4 out of 10 classes each day, or complete all in-class activities and assignments. The strategy is to employ behavioral management through a rewards coupon system where junior earns a coupon each time he attends and participates in class. At the end of each month, if he has accumulated enough, he can trade them for a reward. Another goal, refrain from initiating fights or arguments with other students. Objective, we can use play therapy for 5 sessions to increase his sensitivity and build up his empathy, utilizing role play. And you can show kindness to classmates once a day. Strategies, role play and play therapy. Number 5, one of the things that we recognize is that part of why he's acting out might be because he has not properly grieved the loss of his mother. So we identified that as an underlying factor. So discussing in detail the story of the loss and by expressing his feelings about the death of his mother, and we can do that for 3 sessions so that he can get it out of his system. Right there, we can also allow junior to cry so that can help him relieve his feelings. Another objective, assigning him reading assignments about the grieving process and identify what stage he is currently at so that it can properly be dealt with and moved along. Strategies include talk therapy and also homework. In utilizing the different methods, parents and caregivers, teachers will be asked to assist, and that is an integral part of this particular therapeutic intervention. How we would include them, our goal is to teach the parent and teachers about conduct disorder. That goes right back to psychoeducation, and we can teach the family members how to identify the disruptive behaviors and how to cope with each of them so that they also don't contribute to the behavior. As I said in the strategy, they're taught the principles, relational principles about the disorder and how best to cope with it, and also how what resources they can look at, books, videos that can address the behavior and just provide support for them. Another goal for the parents and teachers: encourage and compliment Junior on his achievements, no matter how small. Encourage Junior verbally when he completes a treatment objective, or he does something kind, or he behaves appropriately and performs well at school. Another objective: compliment Junior on good behavior. And this will let him realize that not all of his behavior is bad. In the contingency contracting, to promote the new behavior in Junior by creating a contingency that must be met in order to receive a desired reward. So objectives under that could be to identify rewards that can be awarded to him every time he accomplishes a task, and actually reward him when he accomplishes a task that is set out within the treatment objectives that were directly for Junior. In the closing phase of treatment, we can increase the family's ability to maintain levels of independence by recommending a group that Junior can become a part of after completing therapy, and 2, recommended workshops that Junior's parents can attend that can improve their parenting styles and be better support for Junior in his healing. All right. We'll look at ethical considerations at this time.
Thank you. Okay, well, here in in Jamaica, you know, we don't have a formal ethical committee or a body that really governs psychotherapists. However, we have learned that we should abide by the codes stipulated by the codes and the principles that are stipulated by the American Psychological Association. And in the case of Junior, we saw some ethical codes and principles that are relevant. Not that all of them wouldn't be relevant, but we just decided to, you know, zoom in more on these. 3.10, informed consent. What we're saying is that since the child is a man, he's not able to give consent therapy. Only the parents can give us consent. However, Junior can give assent. So the counselor should ensure that informed consent is obtained before establishing a therapeutic relationship. As it relates to disclosures, the therapist at some point may require to, you know, provide information about Junior's progress to his teacher, because remember that his teacher had referred him, so, you know, who knows, the teacher may want to know, you know, how he's doing. However, before she can disclose the information, she should ensure that she gets the appropriate consent from Junior's parents, and should also inform Junior, you know, and get approval somewhat from him. Avoiding harm. Every counselor, whatever the context, should ensure that they strive not to cause harm to their client, right? And in the case of Junior, we're saying that this is very important because children are vulnerable in that they are less able to defend themselves from harm from their therapists. The next code that could apply is maintaining confidentiality. APA stipulates that every counselor, every therapist is should adhere to this code by ensuring that he or she protects the client's private information. As such, the therapist should protect Junior's information, and this can be done by securing the client's file in a cabinet that, you know, can be locked with a key that only herself or maybe the office, supervisor, the counseling supervisor has access to. If a computer is used, it should be password protected. So in essence, Junior's information should be readily available to any and everyone. The limits of confidentiality. No, this is crucial because if at any point in time Junior has threatened to harm himself, then the counselor is supposed to breach confidentiality. However, he or she cannot just do that. He or she will have to discuss this as a possibility with the client. So say, yes, whatever you say to me will be held in strict confidence. However, if you see where you pose a threat to yourself and possibly others, then I am mandated by law to divulge information. And of course, there will be documentation of this. All right. As it relates to the principles, next slide. As it relates to the principles, APA has 5 of them: beneficence and non-maleficence. This where the therapy should ensure that no harm is done to Junior. And fidelity responsibility, the therapist should ensure that he or she builds trust and acts in a professional manner at all times when dealing with Junior and his parents. Principle C, integrity. This is where the therapist should ensure to be honest with Junior about treatment, and if there's a third party involvement, when does he need to speak to he or she needs to speak with Junior's mother, will the teacher need to get information about him, and etc. The justice, that's principle D. The therapist should recognize that all persons in the case are to be treated fairly and justly. So, for example, Junior should not be treated unfairly because he's a child and he has no rights. All parties involved should be treated equally. All right. Principle E, respect for people's rights and dignity. The therapist should ensure to respect the rights and the dignity of all those involved in the case, including little Junior, of course. As it relates to the cultural, next slide, applicability. We realize that counseling is a fairly new phenomenon in the Jamaican context, right? And as a matter of fact, it was quite interesting to note that I saw this author said that CJ's degree in counseling in Jamaica, followed by UWI, right? And we want to say that even though counseling is relatively new, the issues that children, teens, and adults face are not new. These issues have been around for generations. Next slide. Right? I want to say also that a number of issues that people in the Jamaican and other persons in other parts of the world face them too. All right. For example, conduct disorder, right? And many of the risks, the protective, precipitating, perpetuating, and predisposing factors that are present in the US, they are also present here in the Jamaican context. Earlier in the presentation, we heard where some factors that can contribute to the conduct disorder from in the US context. Those factors include parental factors, low socioeconomic status, biological factors, and we also heard that some of those very same factors were present here in the Jamaican context among children with conduct disorder. As a matter of fact, there was a study conducted with Jamaican children, and this was noted there's a high prevalence of violence and crime and increasing numbers of aggressive and violent incidents among school-age children. Not only that, but externalizing disorders were prevalent among 12% of children aged 5 to 6, and none of these children had received assistance for their behavioral problem. So what we're saying is that conduct disorder is very much present in our Jamaican context, and as such, there's a need for this to be addressed. Now, in addressing these behavioral problems, CBT is one approach that is quite fitting for the Jamaican context, right? We see here that CBT is an emerging trend in the care However, for it to be effective on the population, it should be problem-oriented and focus on attainable goals. Now, given the fact that CBT is a problem-focused approach to helping people identify and change dysfunctional beliefs, thoughts, and patterns of behavior that contribute to their problem, we realize that it is very much relevant to the Jamaican context because our people also have dysfunctional thoughts which can affect their behavior, bring on other problems. All right, research has shown that. Next slide.
For
As it relates to, yes.
The role,
go ahead.
The family plays an integral role in the process. So we want to ensure that there's a weekly consultation geared towards helping the family to work through the existing problem. We want to give homework that is relevant to the client's issue so that the family can negotiate and assign help to assign these tasks that we want to give. Involving the parents in the therapeutic process also promotes the view that the therapist has confidence in the ability of the family working together, thus reinforcing the perception that the therapist trusts the family to get the best result for the client. Next. Recommendations for families to look at their parenting styles. So often within the Jamaican context, we hear that children must be seen and not heard. But in reality, children has a voice because ever so often they demonstrate this through their behaviors. And if we allow them to speak on critical matters, then chances are they will be better able to navigate these kinds of behaviors. We want the parents to participate in training sessions in relation to their skill sets. We want them to also model the behavior that they want to see in their children. Watching videos can also be a helpful tool for the family to see how best what it is to really and truly be a parent, and also the different parenting styles. Help to do the homework with the child that has the presenting problems, and we want also them to collaborate with the teachers of these children. Next slide. We are of the view that CBT is in line with Scripture, simply because it is geared towards changing people's belief, their thoughts, and how they feel about a particular situation. Proverbs 23 verse 7 speaks in relation to that. In addition, many Bible passages are helpful in replacing individuals' irrational belief with rational belief, or helpful. One and the same books in the Bible. Proverbs in particular contain much information in regards to how we go about changing our minds. According to Dr. Neil Anderson, from a Christian perspective, CBT is very much resembles the idea of repentance, which translates literally a mind change. So we are saying that looking at CBT and looking at Scripture, we see that there is compatibility in them. Romans 12 and verse 2 and Corinthians also support CBT in its approach. It is geared towards transforming the mind of the individual, and if you transform the mind, then the belief and the behavior will also change. Next slide. So in concluding, Alison.
All right. To conclude now, we see that conduct disorder describes the behavior that children who are persistent and continuously violating others' rights, and it occurs, based on research, more among males than it does with females. A number of factors contribute to conduct disorder, which can include parental factors, biological, and socio-economical factors. The major presenting problems need to be thoroughly identified before intervention can even begin. It is vital, therefore, to conduct an organized and thorough case conceptualization. A number of methods can be used, and those are behavioral observations and interviews to arrive at the DSM diagnosis, as well as assessment tools such as Child Behavior Checklist or CBCL, and the Goodman's Strengths and Difficulties Questionnaire. In using CBT to treat cognitive conduct disorder, a number of strategies can be used, and that can include psychoeducation, social problem solving, contingency contracting. CBT is one of the most effective means of treating conduct disorder, because it can teach a child how their thoughts can affect their actions. It also teaches them how to confront destructive thoughts and identify coping mechanisms and improve communication with others. The therapist must be mindful of the children's level of cognitive development and their mental ability, and it would be much easier for the therapist to meet the children at their developmental levels by creating activities and sessions so that the therapy can apply to that child. And the following slides as we continue are the references. Everybody can look through that and follow along some of the links so that more information can be found on cognitive behavioral therapy and how it can be utilized not only in treating conduct disorder but in other disorders. Thank you.
Thank you all for listening, for Dr. Matt facilitating and being up with us at this hour.
Dr. Mack, your mic is muted. We're not hearing you.
I'm saying this is an outstanding presentation, very good. It really captured the essence of what CBT is, especially with with people with conduct disorders. In fact, all the presentations were excellent. People did a good job, and the research was outstanding. I don't think we have any questions. I think it's pretty clear cut for those watching by YouTube and those on the live chat. Just want to take the time to thank everybody, especially Mr. Nyame, for staying up beyond the call of duty to have this class going, and everybody for the cooperation in having the syllabus caught up, and we got a lot of things done between last night and this morning. Well, 2 days of catching up with the paperwork. So I hope the course was beneficial to you. We don't know. You have learned a lot about how to work with children and teenagers, and it was my pleasure working with you and teaching you. Any comments before we go? Any comments?
I have a question, Dr. Mack. Well, a reminder. You had promised some notes last night, and the persons on YouTube and I guess us here in the chat room are asking you to remember to put them up.
I will send them later on today.
Right, thanks. And the next thing is for the cases that we're to work on in groups. Do we require an evaluation for that as well?
Yes.
Peer evaluation.
The group leaders need to evaluate people for contributing to the present, putting it together. Yes.
Oh, it's just the group leaders that evaluates the members.
No, well, the evaluation was given to the group leader. If you have concerns, talk to your group leader about it. Or if you have concerns, you can email me, and I will have to go at that level. But that's basically, so you need to talk to your leader, or that you can send me an email if you have concerns outside of that, Ms. Crawford.
Just checking.
Dr. Mack.
Goes on YouTube.
Yes.
Thank you so much for 4 weeks of grueling information and practice. We thank you so much for your patience with us and for accommodating us read those assignments. I really do appreciate it, Dr. Mack, and I know I speak on behalf of the entire class. Mr. Nayami,
Yes, and then coming from Victor as well.
You are a general. My hat off to your friend. I so appreciate you, man.
Yes, he's yes. Yes, we do appreciate and thank him again for that. And I enjoy teaching, and I'm hoping that you will be able to impart this information with children in your future practice. This is going to be needed information, so don't throw away your notes. You will need them later on. Okay.
Blessings, Dr. Mack. Nadia, we meet after for 5 minutes on our chat.